Hello friends, welcome to the YouTube live session. We have image and video based MCQs from OBG being discussed today. So we've had a lot of sessions which are ongoing simultaneously. So we've had a session of PYQs recently where clinical questions, some 30 odd questions, 35 questions I had discussed. Then some images were there. And also we had the LRR session on the app. A lot of images were there also, and yet we have more images remaining, and those images I'm going to show you today. Some images are simply spotters because for rapid recall we want that like that. Other than that, I've also tried to create new questions. I've also tried to think about the possibility of questions which can be created from some common findings in the gynae OPDs, or common obstetric findings, right? All right, so I think the session, just to give you a time frame, I think the session would be about 2 hours approximately. All right, and I also want to tell you, so I have Neetu here, I have Rashi, I have Galaxy, Zed, Akshay, some Abhishek, and Kiran, and I have Haripriya, Anand, all of you people, Nima, Kaku, and Shiva and Dev Kaushik, right? So just to get a hang of your names as to who is watching and who is there. And good evening, Shubhi, Leena, Tamil. And in case now I'll stop reading the names now, okay? Suparna and Ankita, Kiran, Sayani, all of you, welcome to the session. Just a broad overview. I want you to stick to the images and let us not digress, okay? Time is crucial, and you have other subjects to do also. You have exams coming up, right? So relevant doubts pertaining to the image, pertaining to the question, please post them there. If you further have doubts, then those doubts I will take up at the end of the session for those who wish to, sit there and continue discussing the doubts, right? So for now, as far as the session is concerned, please stick to the images so that we can complete in time. Okay, so let's get started with the first question. All right, so there's a 28-year-old primey, 36 weeks. Her bladder has been emptied, knees are slightly flexed. So just they're describing the position of the patient, and you are performing abdominal examination. There's a maneuver that is being performed. This step determines what? What do you get to know by performing this maneuver? Yes. So B, is it the position of the presenting part? Some of you are saying C. So A, whether the presenting part is engaged or not. See, this is the pollic grips, okay? This is the pollic grips where we are using one hand, okay? At the most, it will tell me that yes, there is head there, okay, or there is if there is head there, I will be able to feel it in my hand. I will be able to lift it up also, provided it is free floating. All right, now how much has it gone inside the pelvis? That information I will not get by doing this third Leupold maneuver. So whether it is engaged, whether it is well flexed head, that extra information not from this script. So this is not the answer. Position of the presenting part is also not the answer. Yes, you're right. So I'm getting some words here like ballotable or not. At the most, only that much information. If it is free floating head, ballotable, that I can know. But how is it just fixed? Is it really engaged? How much inside the pelvis it has gone? That idea we will not get from this grip, right? So it will only tell me about the presentation of the fetus, that it is, yes, cephalic and it is still mobile above the pelvic brim. This information I can get. Now, which fetal pole occupies the fundus? It will not tell, no, that will be from the fundal grip. So obviously D is out, right? So just to summarize here for you people, look at this. This is these are the Leupold maneuver. This is the first, second, third Leupold and fourth Leupold, right? This is the Pollock grips that we just discussed in the previous question. And this one here, the fourth one, is the pelvic grip, where we are using both hands. It is the pelvic grip which gives an idea about the engagement, descent and flexion of the head. So this here I'm seeing, I'll just mark it star. This is the pelvic grip. Okay, this is giving idea. So how much it has gone in, right? How many fifths palpable above the pelvic brim it is, right? Whether the fingers are converging or diverging. If the fingers are diverging, then I'll say lightly engaged. If the fingers are converging, then I can still go beneath the head. That means it may not be engaged, right? So this extra information comes from pelvic grip, where both hands are used. Keep that in mind, okay? And it is the lateral grip which gives an idea about position. So when we do the lateral grip, we figure out where is the back side. Back is on the left side of the mother, back is on the right side of the mother. Obviously where the back is, that is where the occiput is going to be. Isn't it? Right. So wherever the back is, that is where the occiput is going to be, if you're talking about cephalic vertex presentations, right? So it is the lateral grip which gives me some idea about the position, whether the occiput is on the left side or possibly occiput on the right side. Okay. So keep that in mind. Now moving on, identify the position. Identify the position on the left, on the right. All right. So on the left we have, can you see? So these can be image based questions. You can look at the image as you are looking at the patient. So again, left and right are that of the patient, and this is anterior and this is posterior sacrum, right? Look at where the posterior fontanelle is, right? So this is the triangular posterior fontanelle. Back is on the left side, occiput is on the left side, posterior fontanelle is on the left side, and the sagittal suture is obliquely placed. So this is left occipito anterior. This is left occipito anterior. Okay, fine. अब एग्जाम में कितना क्लियर होगा, आइडियली तो इतना क्लियर होना चाहिए कि it has to be clear, otherwise I don't sit on the examination hall and I don't see what kind of images they give you, right? But we can be as close. I think most of the times the images are clear. Okay, fine. Now also remember here that the fetal heart rate is also best heard anteriorly when we're talking about occipito anterior positions. Okay, whether on the left side or whether on the right side. And rightly said, yes, rightly said, movie masala quickly answered. Okay, that is, this is right occipito-posterior on the right side, right? So back on the right side, occiput on the right side, and look at the occiput, which is towards the maternal flanks now, right? So look at these clinical clues in the question. Sometimes the image may come with clinical clues, or a clinical scenario may come where you are needed to identify the position. Okay, so we are covering extra bits also. Please remember that this can be with a stem of the question with these findings, right? So infraumbilical flattening, limbs are more felt anteriorly, fetal heart rate is at the flanks. Okay, and on PV mostly it is the anterior fontanelle which is felt very easily because the head is often deflexed. That is why. All right, so you can see here, this is the triangular fontanelle that is directed posteriorly, and this is the anterior fontanelle directed anteriorly, right? So keep these important pointer in mind. Now Omar, for your question, how do you identify face presentation? So look at this here. Now this is face presentation. Keep this image in mind, kind of keep this image in mind, right? So you can see here that on per abdominal examination, you will feel that it is cephalic only. It is cephalic only, but the head is extended, no? This is extended head. So you can see the diameter here is submentobrachmatic. Diameter here is submentobrachmatic, which is 9.5 centimeter. In this image, we are seeing mento anterior, right? Because the chin is directed anteriorly. So mentum or the chin is the denominator. right? So on per abdomen examination, you'll get an idea that, okay, it is cephalic presentation only, but further information could be limbs are felt more anteriorly. And the other very crucial clinical clue is that the fetal heart rate is best heard on the same side of the limbs, which doesn't happen in vertex presentations, okay? In vertex presentation, the fetal heart rate is heard best on the same side as the back, transmitted through the back. In face presentation, fetal heart rate is best heard on the same side as that of the limbs. This is a per abdominal examination clinical clue. On PV, malar prominences, these malar prominences and the mouth. Malar prominences, mouth, they maintain a triangular relationship. These are clinical clues. Of course, one can go for ultrasound to confirm as well. Now, remember here that mento-anterior vaginal delivery is possible. Remember here that face delivers by flexion. Face delivers by flexion. These crucial points to make a note of. Also make a note that if there is persistent mento-posterior position in labor, then there is no vaginal delivery possible, then cesarean section has to be done. Now, image in the center. Image in the center, you can see here what is this presentation now, and you can give me the diameter also. Your clinical clues, free floating unengaged head on PV, just forehead and supraorbital ridges felt. If those are the findings during examination, during clinical examination, we think bro presentation, right? The diameter is this largest mento-vertical diameter, right? So you know that there is no vaginal delivery possible with bro presentation. So persistent bro presentation in labor, management is cesarean section. Okay, right? Now, mento-vertical diameter, right? Mento-vertical diameter is not 11.5. AIMS has corrected, it is 14 centimeter roughly, right? So it's a very large diameter. Okay. Now, image on the extreme right, what are we are seeing here? We are seeing the occiput is directed posteriorly, right? And directly posteriorly, right? Towards the sacrum directly, right? But it is still the vertex that is coming out. Okay. So make a note of that. It is still vertex. Right? That is delivering first. This is direct occipito-posterior position. In this situation, vaginal delivery is possible. It is possible provided the woman is getting good contractions, she has a spacious gynecoid or an anthropoid pelvis, then okay, then your vaginal delivery will be possible. Now, it is the occipitofrontal diameter which is distending the vulval outlet. Therefore, chances of perineal tear is more likely when face to pubis delivery happens. So this is what we call as face to pubis delivery. And please remember, the delivery of the head will occur by flexion followed by extension. Clear so far? Any doubts in these images? We move forward. Okay. Now, moving on, let's have a look at the next set of images to identify. Again, clinical clues to identification of malpresentations, right? So what do we see here? We see here these are breaches. How we are going to identify? Usually the fetal heart is somewhere near to the umbilicus. The feet on per abdominal examination, obviously you'll know that the head is felt on the fundal grip. Obviously, head will be on the fundal grip, but your fetal heart rate is somewhere close to the umbilicus, somewhere in the center, right? So keep that in mind. Other things on PV findings, they may tell you that only the two ischial tuberosities, the buttocks are felt. This is frank breech, right? They may tell you that the buttocks are felt alongside, there are feet also felt on PV. This is complete or flexed breech, right? And they may tell you that on PV examination, what is felt? Only the feet are felt. One or two, could be both, okay? So only the feet are felt and the buttocks are high up. And feet are felt. This is footling breech. Right, so very good, your identifications spot on. If you look at the next image, okay, clinical clues to identification of transverse lie, right? So when I say transverse lie, it means shoulder is occupying the lower pole, right? So these are shoulder presentations, right? What are they? They are transverse lie. Transverse lie, right? So back anterior is dorso anterior, back posterior is dorso posterior, left or right depending upon where the shoulder or head is. So this is, both are on the left side, okay, dorso anterior, dorso posterior. Okay, now hand prolapse can happen as a potential complication, right? Cord prolapse can happen as a potential complication if these women are allowed to go into labor, right? Now fundal height will be less than the period of gestation, head is felt in the flanks, FSH is best heard below the umbilicus. Very, very important, highlight this clue, the pollic grip or the pelvic grip is going to be empty. Okay, now sometimes what happens is that the woman could be, presenting too late in labor with advanced labor, and the shoulder is pushed down, this part of the body of the baby is pushed down into the pelvis, right? So sometimes that can be there, and then the pollic or pelvic grip may not be empty, and that creates confusion. And on PV, then we should be able to feel the gridiron feel of ribs on PV, These are clinical clues. Of course, if we have a doubt, then obviously we can go for ultrasound for confirmation of fetal malpresentations. Ultrasound is always available to us. Keep that in mind. Transverse lie at term is identified, not yet in labor. We plan for ECV. Supposing there is a situation where ECV is not done, supposing for whatever reason, patient was not willing for ECV, she was not fulfilling the criteria for ECV, whatever be the reason. Okay, if ECV is not done, then we plan for elective cesarean section at 39 completed weeks, or obviously plan is to do it at 39 completed weeks, but if before that only she goes into labor, then we'll do it before that. So, or earlier if she goes into labor. In the meanwhile, such patients are usually admitted for safe confinement at term. What happens is patient may live far away, she may, various factors are taken into consideration. She may live far away, she may not be able to come to the hospital in time, and then, if she goes into labor at home, then cord prolapse may happen. So safe confinement ke liye these are usually we counsel them to stay admitted for safe confinement at term. Okay, now you are asking ECV which week, right? Now see, so you've gone beyond the discussion of the images. So I wanted you to stick to the images, but I will talk about that question in a bit. First, answer this question. A 26-year-old multiparous, 39 weeks, frank breech is in second stage, cervix fully dilated. Now, why am I reading the stem of the question also? Now, again, I've created this question for you to understand extra points. Like, for example, if a woman with breech is undergoing delivery, right, what we tend to do is allow the delivery spontaneously up till the trunk. Okay, right? It is the delivery of the shoulders, the arms and the head that is assisted. Okay, so that is what we call as assisted breech vaginal delivery, right? So cervix fully dilated, trunk and arms have delivered to the nape of the neck. The obstetrician performs the maneuver is shown while the assistant presses suprapubically. By what principle does this maneuver affect delivery? Yes, this is Morrisseau-Smellie Wheat Shubi, you are right, and all of you are right when you say option number A. The whole idea of all of these maneuvers which are going to help in delivery of after coming head in breech is to promote the flexion. So promotes delivery of the after coming head of breech by maintaining flexion. This is your answer. You are right. This is Morrisseau-Smellie Wheat maneuver. Okay, head is not delivered by extension, head is delivered by flexion, and the trunk is swung over the maternal abdomen. When the trunk is swung over the maternal abdomen, that is Burn Marshall maneuver. Okay. Now, you look at this, traction is applied to the mandible. No, traction is applied, as you can see on the side image here, on the malar prominences, again to maintain the flexion of the baby's head, right? Not on the mandible. It will cause jaw injury and, to the fetus. That's wrong, right? So this is what we call as malar flexion and shoulder traction. Malar flexion and shoulder traction, right? So this is what the modified Morrisseau-Smellie wheat is. Originally, they had introduced jaw, fingers inside the jaw, but then that was modified later. Now it is malar flexion and shoulder traction. Suprapubic hand by the assistant also presses like this. Suprapubic hand also helps maintain flexion, but not promote rotation, okay? So this is extra thing that we ask the assistant to do. So we are doing the burn MSV, Morrisseau-Smellie wheat. At the same time, assistant is asked to put suprapubic pressure to promote flexion of the head. So much so, remember, delivery of after coming head of breech occurs by flexion. Okay, clear? Now let's have a look at these maneuvers. This is Burn Marshall, right? The trunk is rotated, the trunk of the baby is rotated. The legs are lifted up gradually and slowly, not suddenly, gradually and slowly towards the maternal abdomen. This is Piper's forceps, again for delivery of after coming head. Prague maneuver for delivery of the head when back turns posterior. Pinard, P for popliteal fossa, finger in the popliteal fossa. Delivery of extended leg. Groin traction is for delivery of buttocks. Drusen's incision is for delivery of after coming head when we give an incision on the cervix. So that means that the head has stuck behind an incompletely dilated cervix. Please remember that we do not give this incision at 3 and 9 o'clock. Okay, not at lateral sides, because there is this descending cervical branch. We may cut the artery and then it will lead to a lot of bleeding. And the first one here, which is left blank, is the Lofset's maneuver. So I remember when you are in love, you are hugging your person, you're extending your arms, calling for a hug. So this is your for extended arms, for delivery of extended arms. Try to remember it like that. So it is for extended arms and obviously shoulders as well. Okay, so this is Lofset's maneuver. Now coming to your question. Coming to the question, clinical management of breech presentation. Breech presentation, so you were asking about, somebody was asking about external cephalic version. All women should be offered external cephalic version, as you can see in the image, at term. When I say term, that means a good idea would be any time beyond 37 weeks, once 37 weeks are completed. In primigravidas, beyond 36 weeks we can also do, but by convention, let's remember one value, 37 weeks. So it's not like it has to be, if it is not done at 37, it can't be done at 38. It can be done any time at term once 37 weeks are completed, and by convention we plan for 37 weeks, right? I want you to remember the criteria that needs to be fulfilled. If you remember that, then automatically you make sense of the absolute contraindications. So have a look, the baby has to be rotated, it has to be moved inside, and it will come with its own inherent set of complications, like there is risk for cord compression, cord entanglement, placental abruption, risk of feto-maternal hemorrhage also. These are some potential complications that can happen, right? So we want, just remember, a healthy mother and a healthy baby, right? If there are some other associated complications, generally it is not preferable to offer external cephalic version, right? And technically it can be done if there is only one fetus inside. Otherwise, how will we move two fetuses, no? So it has to be a singleton fetus. The pelvis should be adequate. The placenta should not be low-lying, right? Liquor should be adequate. Membrane should be present in case the woman is in early labor. Sometimes people attempt it in very early labor also when the os is, closed. Healthy fetus, there should be no gross congenital anomaly, and there should be no preeclampsia hypertension. So there should be, period, healthy mother, healthy baby. Okay. Yes, why not transverse में क्यों नहीं करेंगे? अभी we did the question earlier that in transverse lie, not in labor, then external cephalic version can be done provided the criteria is met. In fact, it is much more easier, no, to do it. It is just, the baby is just, you have to just move 45 degrees, not even 90 degrees rotation, right? Okay, fine. Now, and also I want you to remember this box for your clinical questions. I mean, I start with image based and then I always go clinical. So the thing is, I want you to remember this box where the criteria is satisfied, and I want you to remember absolutely indicated cesarean section. Must do cesarean section if it is breech. One is foot-link breech and the other is breech with hyperextended head. In these two situations, there's always a cesarean section that needs to be done. When there is breech with associated complications, generally we give preference to cesarean section. Okay, it's not like absolutely it is needed, but generally the preference is that. Okay. Now, yes, you'll get a PDF later. All right. Next question. A 25-year-old primey came at 32 weeks. She's sure of her dates. Symphysiofundal height is 28 centimeter. Blood pressure is normal. There is no leaking or bleeding. She is not perceiving fetal movements for 2 days. Fetal heart rate cannot be localized on stethoscope. What do you want to do next? Okay, just read this question. Meanwhile, I will take up Janvi's doubt. Any anesthesia required? Bache, this procedure, which is external cephalic version, Janvi, this is your doubt, very relevant doubt. It is not done under anesthesia. Okay, it is done on an OPD basis, but we need what is most important, it has to be done under ultrasound guidance or CTG guidance because of the associated complications that may happen. And ideally, I want to plan it in a manner that my OT and team knows that I'm doing a procedure like this, because if complication happen, I may end up with an emergency cesarean section also, may end up, right? So I make things ready. I plan to do it in the OPD under ultrasound guidance, right? And other thing is that tocolysis may be needed. Acute tocolysis may be needed. I mean, we have to consider on a case-to-case basis, right? Sometimes it is difficult to do, especially in primary gravidas with tight abdominal wall. Then one may think it's not like it's not needed all the time. Okay, so that is the answer. All right, now coming to the question, ultrasound, 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 NST. Now, those of you who are saying NST, please, just one word for this question. Okay, she's not perceiving fetal movements. The fact is that FSH cannot be localized on stethoscope. You're trying to listen. It's not being localized. It's all quiet inside. Okay. Now, even if you're going to use a handheld Doppler or NST, that tuck, 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 tuck of the NST probe, what is that? You are listening. You're still listening. Okay. You may see that visible graph, right? Of course, that is there. But NST can pick up even maternal fetal heart rate. Okay. It works on, NST also works on the principle of Doppler only, right? You're still listening. Now, the priority is to know if the baby is actually alive or dead, right? You have to document fetal heart rate here. Documentation of fetal heart rate, of cardiac activity is important in this particular situation right now, right? So it could be IUD, it could be IUD. 32 weeks, fundal height 28 centimeter only. She's not been perceiving fetal movements. I don't know, maybe the baby has long been dead, or it was a growth restricted fetus, now dead. I mean, that I need to rule out first. Okay, so by that priority, answer is ultrasound for this particular question. Okay, right? And I mean, once I have done that baseline ultrasound, I will also get other extra information. No, I'll confirm that the baby is live or not, if the baby is growth restricted or not, if there is a need for fetal Dopplers now, because supposing I identify fetal growth restriction, then I want to evaluate further. So it then and yes, it will then open up the possibilities of the differential diagnosis and further evaluation. So right now, I want to do next ultrasound, not NST, not biophysical profile, not fetal Doppler. I want to request for NST. Sorry, request the sonologist to do an urgent ultrasound for this particular patient. Okay, fine. So I think I've answered why not fetal Doppler. Okay. Yes, if fetal heart rate is present and you are, if fetal heart rate is present, then further evaluation when a woman presents with decreased fetal movements is an ST. Is an ST. Yes, of course. But understand here that every investigation has its own value. All right, and what investigation we do will depend upon the clinical profile of the patient. So if the clinical profile of the patient is saying that she's having decreased fetal movements and I have doubts about fetal growth restriction, then I will investigate along both lines, right? The scenarios that are given to you in exam, I have a question for that also. So I think where your doubts are coming, we will come up to that doubt also. Right, now Dhanush, you're saying up to 4 weeks discrepancy is normal. No, symphysiofundal height in centimeter beyond your 24 weeks of gestation up till 36 weeks. It is plus minus 3 centimeter. It should correspond plus minus 3 centimeter with the period of gestation. Okay, fine. Now next question, the next image. Let's have a look at this. Let's have a look at this. NST image, yes, what we are seeing. What I need you to remember here, the characteristics of normal CTG trace. Characteristic of normal CTG trace. Okay, so this can be an image-based question. They can tell you that a woman came with decreased fetal movement. She was subjected to this particular test, right? We see that the woman is holding something in her hand and she's pressing on it. That is for recording the fetal movements, right? So this is the CTG machine. How do I know NST is being done? It is done using the same CTG machine, analyzed by the same principles. Let me tell you, when I say non-stress test, the stress of labor isn't there. She is not in labor. The same CTG machine is being used, okay, right? So NST meaning non-stress test, meaning there's no stress in labor, right? So she's not getting contractions. She's not getting contractions, this patient. Okay, and in this image what we are seeing, this is acceleration, this is also acceleration, this is also acceleration, right? So we see reactive NST should have all the normal characteristics, should have baseline normal, beat to beat variability normal, no deceleration should be there. Accelerations could be absent. Acceleration could be absent in laboring patient. I am saying patient is not getting contractions, I am doing NST. Right. So accelerations, I will say reactive NST, at least 2 acceleration in 20 minutes, each lasting for 15 minutes and each having at least 15 beats above the baseline. Okay, so this is the criteria for reactive NST, and this criteria applies when the pregnancy is beyond 32 completed weeks of gestation. For preterm babies, then this criteria has to be relaxed a little bit. Then it is two accelerations, but 10 seconds and 10 beats per minute. So that criteria has to be relaxed a little bit, right? So NST tells me, what does NST tell me? NST serves the purpose, it tells me right now the baby is doing well. Acute status of fetal well-being. That is the only information I get from this, that right now baby is doing well. It is more of a test of wellness rather than illness. Now if you look at this question now, these are the sort of profiles that they will give you, okay? Not complicated mixed profile where patient has decreased fetal movements also, fetal growth restriction also and all that, right? So here, primigravida, let's say, presented with complaint of decreased fetal movements. There's no history of abdominal pain, leaking or bleeding. Per abdomen shows term size, uterus relaxed, not in labor. NST is done and strip is shown below. Now this is not a reactive NST. What we are seeing here is non-reactive findings. Okay, we are seeing that the variability is reduced, we are seeing that there are no accelerations. So what is the most appropriate next step? The most appropriate next step, yes, perform NST for full 40 minutes before labeling as non-reactive. Why? Because there can be non-reactive NST, there can be decreased variability even when the fetus is sleeping inside. So fetal sleep cycles also happen, in which there can be temporarily there can be decreased variability or non-reactive NST while the baby is sleeping inside, right? So a good idea would be to perform NST for full 40 minutes before labeling as non-reactive and not immediate jumping. And of course we will not ask her to, this is not good, so I can't ask her to follow up 1 week later. Okay, now Dhanush, then also not vibroacoustic stimulation. Yes, vibroacoustic stimulation could be done during the NST procedure. That also is a possibility if that artificial larynx is available. to us. Most of the time it is not. Now, biophysical profile is the next step if the non-reactive NST is there, right? So if non-reactive NST you have labeled, then you want to go for a full biophysical profile also. This is Manning score. Okay, remember what is included in Manning score. NST we must have already done. Fetal breathing, gross body movement, fetal tone, amniotic fluid volume. In this situation we want at least a 2 by 2 centimeter pocket, at least a 2 by 2 centimeter pocket, and based on the final score we are going to plan for delivery. What I need you to remember is score 10 by 10 or 8 by 10, that is reassuring. Score 6 by 10 is equivocal. When equivocal scores are there, see, decision about when to deliver or not, or whether to deliver or not, depends on many factors, not just the biophysical profile, patient profile, what is the diagnosis and all that, right? So we'll not go into too much detail with that. What I want you to focus on is another test which we can do is modified biophysical profile. Okay, so sometimes, you know, I have, like, for example, I'll give you just a profile. Like, for example, this patient. Who had come with decreased fetal movements. Okay. Now, I prioritize doing NST for this particular patient. If on clinical examination, supposing I also feel that the amniotic fluid volume, if clinically I feel that the Liker is less, if there's any doubt about the fundal height, if I feel that the baby could be growth restricted, I mean, I can go for this also, no, modified biophysical profile, cut short the time. For 20 minutes, we do the NST and just put the probe on the abdomen and check the AFI. So in the image on the inside, I'm showing you how we check for the AFI, right? So you can see here, I'm just measuring the AFI. I'm measuring the amniotic fluid pocket. I'm measuring the amniotic fluid pocket, vertical cord-free amniotic fluid pocket in one quadrant I'm seeing, right? Now, similarly, I'll do in all 4 abdominal quadrants. So AFI would be sum of all 4 quadrants. Okay, so whatever pocket I see here, like here I'm seeing a 2 centimeter pocket, for example. So 2 plus 2 plus 2 plus 2. So that sum will be the AFI. Okay, sum of all 4 quadrants in centimeters. I will measure the pocket in each quadrant, and then I will add them up. That will be the AFI. Normal is 5 to 25 centimeters. Okay, and single deepest pocket, yes. So AFI is 5 to 25 beats per minute, 5 to 25 centimeter, and single deepest pocket 2 to 8 centimeter. How do we check for fetal breathing? We check for the fetus rib cage movements, fetus diaphragm movement. That is how we visualize it on ultrasound. All these parameters are seen on ultrasound. Ultrasound is done for full 30 minutes. Okay, so when we do Manning score, NST 20 minutes occupied there, plus 30 minutes of the performing the ultrasound. Okay, clear? Next question, image-based question. If you were there with me in the PYQ session also, we had a similar question, but that was a different question. Okay, now let's see if you can solve this question. A 32-year-old primary at term was admitted in active labor, same profile, but analyze the partogram and tell me the management. If you look at the options, oxytocin, urgent cesarean section, or performing ARM, or assessing for something else like malposition and malpresentation. So broadly, the fetal heart rate looks normal, as you can see, right? Amniotic fluid, here they have written that it was intact, membranes were intact. I is for intact membrane, clear, no molding is there. But if you just look at these findings, what do you see? You see that the contractions are more or less good, right? So there were mild contractions initially, then moderate, then good contractions. 3 good contractions in 10 minutes we are getting. Let's look at her progress. Slow progress. Okay, from 5 to 6, then has been stuck at 6 for 2 hours. There has been some descent. From 2/5 palpable above pelvic brim to 1/5 palpable above pelvic brim. But some progress has been there. Yes, the action line has been reached, so I need to take action. Action is not straight away cesarean. Action is not straight away oxytocin. Action is analysis first. Okay, action is based on the findings. Action is based on the analysis, right? So immediate intervention So action means action always has to be backed by the findings first. Okay. So how will we attempt this question? I mean, I'm seeing good contractions. So I don't think there is a need for oxytocin. She's already getting good contractions. For 2 hours, she's been getting good contraction. I'll say there is some progress, slow, but some progress is there. Artificial rupture of membranes, I will do in case she had membranes intact. I mean, Liker is already clear. So what artificial rupture? Membranes are already absent based on this partogram, right? So before an urgent cesarean section, I want to assess for malposition and malpresentation. Why not? Why not? That information is not mentioned in this partogram, right? Maybe it is a ROP position. And maybe then I will decide, okay, that could be the reason for slow progress. Maybe if I'll give her some more time with good uterine contractions, rotation may happen and then she may deliver. Okay. All right, maybe there is a malpresentation. So analysis first. So answer then becomes option number D. Answer then becomes option number D. Now, assessment is done earlier for position before oxytocin and ROM. Of course, assessment is built in. Shinchan, assessment is built in. Any intervention of any kind in any patient, not just obstetrics, is always after assessment first, no? So this is PV findings, no? What we were seeing here, at 2 p.m. At 2 p.m. we did this examination, at 6 p.m. we did, at 8 p.m. we checked the cervical dilatation. We were doing PV, no? So at that time, we were checking the status of the membranes. At that time, we were checking the status of the sagittal suture and the fontanelle and everything. So yes, assessment is built into it, right? How are we knowing amniotic fluid? I guess maybe that is a question from somebody who's not put foot inside the labor room, because then amniotic fluid you will see leaking. That patient will complain of leaking. She must be using a pad, and then you will see the color of the amniotic fluid on the pad, right? Also, okay. So what are you going to keep in mind? You're going to keep in mind that what is arrest? What is arrest? Arrest, you will label arrest in active phase dilatation. You label when cervical dilatation has been stuck at more than or equal to 6 centimeter with ruptured membranes and there is no change in dilatation for 4 or more hours with good uterine contraction. Now this becomes an indication for cesarean section. Otherwise, please remember, whenever there is slow progress in active phase, first look at the 3 P's, power, passage, passenger. First look at the power, contractions adequate or not. If the contractions are adequate or if the contractions are inadequate. If the contractions are inadequate, it needs augmentation, right? So we can see how we can do that. If bag of membranes is present, ARM can be done, which is followed by oxytocin infusion if needed. Oxytocin infusion if needed. Okay. If membranes are already absent, then oxytocin infusion is the option. Okay. Now, if contractions are already adequate, then you are going to go for assessment. Further assess. Maybe you have assessed, but maybe you're the undergraduate. You will call for help, okay, and the senior person will come and assess, right? So reassess. Let's write assess if reassess if already assessed. Reassess for malposition, deflexed head. Because if power is adequate, then what is the problem? Right? Possibility of CPD, malposition, deflexed head, CPD, malpresentation. And that is where the value, that is where the clinical value of identifying malpositions and malpresentations come. And that is why we did the initial slides. Okay? Clear? Right? Now, if there is second stage arrest, or let's say there is prolonged labor, prolonged second stage. Okay, keep in mind, always assess, always look for molding. Always look for molding. Keep that in mind, because molding grade 3 would mean CPD. Okay, fine. So, in this situation, deliver by instrumental delivery only if station +2 or more, no CPD, other criteria are fulfilled, otherwise do a cesarean section. Otherwise do a cesarean section. Okay, so if second stage problem is there, if there's problem after full dilatation of the cervix, okay, right, then only and only if criteria for instrumentation delivery is being fulfilled, then you do instrumental delivery, otherwise you do a cesarean section. Okay. Now, observe the CTG try. So, questions about CTG, one of you is writing a lot of questions about sinusoidal this thing. Okay, sinusoidal is baseline, and baseline sinusoidal you can only see in CTG. Okay. Now, observe the CTG trace of this woman undergoing induction of labor at term with fetal growth restriction. She's getting good contractions, right? So, you can see contractions are there. Okay, and she's complaining of leaking. The liquor is meconium stain. She is being planned for emergency cesarean section because of these findings. What are the findings? The findings are she was going induction of labor. She was at term, but she had underlying fetal growth restriction. She was induced. Okay, now she's also complaining of leaking. Okay, she's being planned for emergency cesarean section, not based on the CTG alone, but based on the entire profile. Okay, not based on the CTG alone, based on the entire profile. Okay, profile of the patient, the CTG showing late decelerations, CTG showing late decelerations which are associated with fetal hypoxia, which are associated with uteroplacental insufficiency. All of these findings or profiles in the question are supporting what? The possibility of uteroplacental insufficiency, the possibility of fetal hypoxia in this patient. Your senior person must have done a PV for this patient and then must have decided, okay, there is no vaginal delivery happening soon, so let us take her for cesarean section. So this kind of judgment making, clinical judgment making takes place in the labor rooms. So from that we have roped in a situation, right? So we can see here the decelerations are each time coming late, and recovery is late. So supine position is a complete no, it is not done, isn't it? So what is not done? Supine position. It will worsen the maternal hypotension, it will worsen uteroplacental perfusion. Left lateral position is the position to be. Yes, it will improve the placental perfusion. If there is any cord compression happening, it will probably relieve that also, the positional changes, right? Oxygen inhalation, yes, to maintain oxygenation of the mother, and then obviously it will be maintaining oxygenation on the baby also. IV fluids, yes, maintain the maternal hydration also. And Foley's catheterization, yes, as a part of prepping up for cesarean section, that will also be included. All right. So yes, you are right, all of you. So you get I think in the previous PYQ session, which was on YouTube, I've discussed a scenario of variable deceleration. Okay, so it requires, my dear friends, no mugging up. There also we discussed and came to the right answer. Here also we discussed and came to the right answer. Now this is the variable deceleration. This is the variable deceleration associated with cord compression. All right, just to appreciate the difference here, you can see that these are broader, these are much broader, these are much broader deceleration if you have a look at it, right? And so it takes time for them, it takes time for the it takes time for the fetal heart rate to drop to the lowest level. Here they are much more rapid, abrupt. They are very abrupt. They quickly fall down. All right, V-shaped deceleration. They can come with, after, above, wherever. They're unrelated to contractions as such. If you look at the image on the right, these are early decelerations. Okay, just an exact mirror image of the contraction, exact mirror image of the contraction. This is because of fetal head compression. Okay, and early decelerations by themselves are not that threatening. Early decelerations alone, not ominous. Okay, and this is your sinusoidal baseline. This is your sinusoidal baseline. What is happening in a sinusoidal baseline? There is a sine wave pattern to the fetal heart rate, baseline fetal heart rate. That is why it is sinusoidal baseline. It is not a deceleration, it is a baseline format, right? So the beat to beat variability, which we tend to see, the beat to beat variability here we are seeing, beat to beat variability with these decelerations we are also seeing. We saw it in the NST traits, the wiggliness of the baseline. That wiggliness of the baseline is no longer there. The variability has gone. Instead, it has become a sinusoidal baseline. This is a very bad CTG trace. It is associated with severe fetal asphyxia and severe fetal anemia. You can think of the clinical context in which severe fetal anemia occurs. Like for example, there was a bleeding vasa previa. In the clinical context of bleeding vasa previa, fetal bleeding happening. In the context of twin-to-twin transfusion syndrome, one twin bleeding into the another twin. So the donor twin can have this sinusoidal baseline. Or suddenly there is a fetus who developed sudden intracerebral hemorrhage. Okay, then sinusoidal baseline can be there. Or RH affected fetus, where fetal hemolysis is happening all of a sudden, and then that is also causing sudden fetal anemia. So sudden severe fetal anemia, this clinical so you can think of the clinical contexts around which severe fetal anemia can be there. ABO incompatibility does not cause fetal hemolysis. ABO incompatibility you read in pediatrics, it's a newborn presentation, right? Now category 3 traces, I told you what is absolutely normal when we began looking at the CTG trace, okay? This is something that is absolutely normal, absolutely abnormal. Category 3, delivery has to be expedited. Also, all the measures that we have to take, taking her in left lateral position, oxygenation, IV fluid, all that resuscitative measures, those are also taken, and the patient has to be mobilized for delivery, right? Delivery has to be expedited. How is another matter. Okay, whether vaginal, whether cesarean, or whether instrumental vaginal delivery, that how is another matter. Okay, so if vaginal delivery possible, feasible, vaginal delivery, otherwise cesarean. Okay, such abnormal traces happening early in labor, vaginal delivery is not about to happen in cesarean section, obviously. Such abnormal CTG traces, abnormal findings happening in second stage labor, criteria for instrumentation delivery is being fulfilled, it is much more feasible to deliver vaginally than you go for instrumental vaginal delivery, otherwise cesarean section. Alright, so keep this logic intact, okay, answer with logic. So there is absent variability with any one of these followings. This is absolutely abnormal, and whatever in between non-reassuring patterns, we say category 2. We start with the resuscitative measures and then monitor the patient for a while and then decide. It's not like there is a urgency, immediate urgency is not there. Okay, clear? Now, let's have a look at this image-based question. Identify the device used and its correct placement. So what is this device used? You can see that the head is being delivered, a cup is placed on the scalp, and there is a handheld vacuum device. Okay, so you may have seen this in your labor rooms, or you may have seen the vacuum cup, a elastic vacuum cup with a tubing attached to the suction apparatus. That's also fine, and it is this is also fine, right? So this is Kiwi Omni Cup. This is Kiwi Omni Cup. This is when we are saying vacuum vaginal delivery, right? So what do you see here about its correct placement? Or a correct placement is this. The center of the cup should be at the flexion point. What is the flexion point? This marked X is the flexion point. It is 3 cm anterior to posterior fontanelle and 6 cm away from the anterior fontanelle. Okay, clinically, how do I know that I have placed it correctly? The rim, the posterior rim, the rim, I see the rim, okay, because when I'm placing it, I cannot look inside and see if the center is at the flexion point on the baby's head. I see the rim. So the rim touches you can see the rim touches the posterior fontanelle, and this rim is about 3 centimeters away from the anterior fontanelle. That is how I know that I have placed it on the flexion point. Okay, fine. So that is the clinical tidbit. Identify these images. Yes, identify these images, some things that you may see lying around in the labor room. Okay, these two you may see lying around in the labor room, and this is something that is a procedural image. So what is we seeing in this? These are all methods for cervical ripening. These are cervical ripening methods. Okay, now the first image is mechanical method, which is intracervical Foley's balloon catheter placement. Okay, fine. Right, this is a mechanical method. The biggest advantage is that it has no drug. No, so what is the biggest advantage is that it is very much preferable. Supposing I have to do induction of labor in a previous cesarean section. So in a previous cesarean patient where I will not want to use prostaglandins, please remember, previous cesarean section, misoprostol is absolutely contraindicated. Keep that in mind. It's absolutely contraindicated in previous cesarean patients, right? So misoprostol is PGE1. This is also a pharmacological method. There's a tablets, misoprostol tablets we can use for cervical ripening as well. Okay, so those are also used by us, or misoprostol tablets for cervical ripening for induction of labor, right? So this would be preferable in previous cesarean patients, but it is not going to be preferable, let's say, in situations where there is already ruptured membranes are there, okay, or leaking PV is there, or bleeding PV is there. Then in those situations, this is not preferable. Image in the middle is cerviprime gel. Cerviprime gel is dinoprostone, which is PGE2. Okay, right? And in normal circumstances, what if we are using cerviprime gel? Generally, the idea is that we can give 3 doses at the rate of 6 hours. Like if 6 hourly, we can give 3 doses. We can repeat based on the findings. Maximum 3 doses in 24 hours. Okay. In previous cesarean cases, if I want to use this, in previous cesarean, I'm very cautious. Okay. I don't want to use it first of all. In case I use it, then I'll just probably give 1 dose. Probably 1 dose. But anyways, prostaglandin PGE2 also will not be preferable in previous cesarean section. If at all I give 1 dose, and misoprostol is definitely absolutely contraindicated. Now this on the right is PGE2 insert Cervidil. Another formulation, same dinoprostone but in the insert form. This is inserted inside the vagina. This is an intravaginal insert. Okay, it is placed behind the posterior fornix. Okay, wrapped up in the posterior fornix around the cervix like this. Okay, wrapped up like this. So it will slowly, it contains 10 milligrams of Cervidil, it contains 10 milligram of the agent, that is PGE2, slow release, right? We can let it stay inside for 12 hours, and in case the woman develops, contractions before that and her findings are improving, then there is an option of, pulling it out and removing it earlier also, right? So 12 hours or maybe earlier if required. So that is the thing, right? Yes, yes, scar rupture, yes, that the misoprostol can suddenly cause intense uterine contractions, and with previous cesarean section there is risk of scar rupture with excessive uterine contractions, of course. So that is the thing. Next question, image based question. I will read through the stem of the question just to emphasize some important pointers, just to jog your memory about what we do in the third stage, just to jog the memory. So there is a multiparous woman at 39 weeks. She is delivered. Injection oxytocin 10 units IM was given. So see, look at the priority of things. Immediately after delivery of the baby, uterotonic. And the cord is clamped after 1 minute of birth of the baby. Delayed cord clamping done. Uterus feels firm and globular. That means the contractions have started. That is, of course, important. Placenta descends and is delivered without difficulty using this method in the image, right? Which of the following is the most important point to observe while performing this method for placental delivery? So please remember, this is controlled cord traction. Okay, controlled cord traction should be done by trained birth attendants. By virtue of your degree, undergraduate students will be expected to be trained birth attendants. So that is why this question, knowing the know-hows of the maneuver is important, right? So traction should be increased in force Absolutely not, right? What is most important? Excellent counter traction. That is the whole idea behind this controlled cord traction. Traction is one part, pulling on the umbilical cord downwards and backwards, and simultaneous at the same time, like this. Simultaneously, we put pressure here in the suprapubic area. We push the uterus. The idea is to push the fundus up. Idea is to push the fundus upwards and backwards, so that counter traction is given in the direction of the umbilicus simultaneously, right? To avoid uterine inversion, and also, yes, of course, that, you know, with one hand we'll also know whether the uterus is contracting or not contracting, right? So this counter traction is a very, very important point. Please remember, traction should be applied only after placenta is in. No, this is not correct. And traction must be applied not between contractions, with contractions, right? With contractions. You see, so that is the whole idea, because if you're going to pull on a relaxed uterus, traction on a relaxed uterus, we'll end up with a uterine inversion. Okay, so your confusion between B and D is gone now. All right. There is no pulling at the cord with relaxed uterus. The whole purpose in the third stage is to keep the uterus contracted. It is uterine contraction that has helped in delivery of the baby. It is uterine contractions which are the main mechanism of why the placenta separates. It is the uterine contractions which are going to decrease the blood loss eventually, that happens or naturally is expected to happen anyways in delivery, right? So that is why uterotonic was the most important component all this while for prevention of PPH. So contractions we need. So pulling, traction, counter traction is done with contractions. Clear? Okay. Next question. This is a video based question. I want you to appreciate the findings. The whole idea in doing these video based questions, or even for that image based question for that matter, is you should know what you want to look for in the image. Okay, that is the whole idea. How you solve image based questions is going to be like this. If you don't know what you are looking for, or what, you know, then you will not see it. Right? So either it is such a classic image that it needs no stem, it is a blanket identify image question, or there will be a clinical profile. So much of the time your answer will be in the clinical profile. So when you look at the options, then you know, okay, now this is what I want to look for in this image. So profile, twin pregnancy, first trimester, scan was undergoing. So yes, the best timing to look for this chorionicity, right? Best timing for chorionicity is 10 to 14 weeks. So this is being done in the first trimester. She is otherwise asymptomatic. What are we seeing here? We are seeing not T sign. We are seeing lambda sign. We are seeing this Y. This Y we are seeing. Let me just... So first, identification. Okay. Yeah. So this, the dip, the Y, the lambda, the dip of chorion in between, the dip of placental tissue, the dip of chorionic tissue in between the membranes. This is the placenta here that we are seeing. This whole thing is the placenta, developing placenta, dip of placental tissue, right? So this is lambda sign in this image. Twin peak sign, it is also called as twin peak sign. And this is seen in dichorionic, diamniotic type of twins. Okay, so the best answer is option number A. If I know that they are dichorionic, then that means that they are not sharing the placenta. That means they are not at risk of twin-to-twin transfusion syndrome. Right? So if they are not monochorionic, they are at risk of twin-to-twin transfusion syndrome. Monochorionic, monoamniotic, they are further at risk of cord entanglement also. But this is not monochorionic, right? So that is the idea of why I want to know the chorionicity. I want to know the chorionicity in the antenatal ultrasound because I want to know what kind of twins they are. Then I know what kind of complications to expect in the patient. Okay. So if I know that they are dichorionic, then I'm sort of relaxed. I'm not on the watch out or look out for twin-to-twin transfusion syndrome happening in this pregnancy. But if these are these kind of twins, then I get cautious for further monitoring in pregnancy, isn't it? Now, they are not, I can't say for certain that they are dizygotic. I can't say for certain that they are dizygotic, right? Because monozygotic can also be dichorionic depending upon the timing of division. So that's another question that they can ask. What about the timing of division? So overall, the most common type of twins are dizygotic. They are always dichorionic, diamniotic. Monozygotic, whether they will be dichorionic or monochorionic, that will depend upon the timing of division, like you were mentioning, you guys were mentioning here in the chat box, right? So within 3 days of fertilization, dichorionic, diamniotic, right here. Okay, between 4 to 8 days, monochorionic, diamniotic, right here. Okay, between 8 to 12 days of fertilization, monochorionic, monoamniotic, this one, monochorionic, monoamniotic, right? No intertwin membrane you can see. And beyond 12 days is conjoined. Beyond 12 days is conjoined, you right here. Okay, so this you can see the intertwin membrane, it's very thin. It contains only 2 amnion. There is no placental dip. Look at these 2 images. Look at this. In chorion, amnion, amnion. Look at this. Amnion, amnion and chorion in between, right? There are 2 separate placentas. If an ultrasound is showing 2 separate placentas, it's obviously dichorionic, diamniotic. One placenta in the anterior wall, another placenta in the posterior wall. Obviously dichorionic, diamniotic. Okay, and this can be a single placenta, but they are not sharing. They are not sharing. So when they are not sharing, you will see this dip. You will see this lambda sign, like I had shown you earlier. So this is dichorionic, diamniotic, and in this image, what we are seeing is, this is an early pregnancy scan. Early pregnancy scan showing 2 separate gestational sacs. Gestational sacs is nothing but chorionic cavities. So this is 2 separate chorionic cavities. So this is obviously dichorionic, diamniotic, but this is an early pregnancy scan. This is an early pregnancy scan. Okay, fine. And this is what you were saying, T sign. This is what the T sign will look like. Do you appreciate the difference now in the 2 sign, in the 2 lambda versus T? Okay, lambda is this. There's a dip. Okay, it was much more appreciated in the previous. This is from a different patient, right? So this is the placenta now, and this is the T sign. No dip. Okay, this is monochorionic, diamniotic. This is monochorionic, diamniotic. Clear? Right? Okay. All right. Now, let's also have a look at this scan. The previous, so this is also dichorionic, diamniotic. Look at this scan video. Again, you would not know if you don't know what you are looking for. If I give you this scan and I tell you, identify the diagnosis, the one video that is playing, right? So what are we looking for in this? I tell you that it is a case of twin pregnancy, 2 fetuses are seen. And then if you know what you're looking for, then only you will find it. So you are finding 2 separate gestational sacs, right? So it is an early pregnancy dating scan. And if I were just to move this, look at this. 2 separate gestational sacs I'm finding, right? Both fetuses are inside. Okay. So now I know that this is, look at this. This one small yolk sac inside. So these are 2 separate in their own, have their own separate yolk sacs, have their own separate chorionic cavities. This will obviously be dichorionic, diamniotic. Okay, fine. Now, contrast that. Now, contrast this. Oops. Look at this. Image on the right, there are two. They have their own yolk sacs, fine, they're two fetuses, but they're in one gestational sac and there is no intertwined membrane. There is no intertwined membrane. We cannot appreciate any intertwined membrane. This is monochorionic monoamniotic. This is monochorionic monoamniotic. Now, with this image, you can understand that these are very high risk. They are at high risk because of cord entanglement. Look at this image. Cord entanglement. Right? And that is why monochorionic monoamniotic are the type of twins that should be electively delivered by cesarean section, elective cesarean section, between 32 to 34 weeks after steroid cover, obviously. Okay, that is supposed to be done. And that's why I want to know the chorionicity, because I want to know what to expect in this antenatal patient, right? Now, moving on, let's look at this. It could be an image-based question. They may put in a small video also, or a small GIF or video clip like this, where they may give an arrow in the end, or they may just tell you that, or they may give a clinical profile. Okay, so what are we seeing? We are seeing the, yes, we are seeing the nuchal translucency. Yes, excellent. So we are seeing the nuchal translucency, right? The fluid filled space at the back of the fetal neck being measured. Nuchal translucency. It is not diagnostic. It is not diagnostic. It is a screening marker for fetal aneuploidy, right? So please understand here, we will say raised NT is abnormal. Raised NT more than or equal to 95th centile for that gestational age. So basically it is a gestational age dependent parameter, but you can remember one value, anything NT more than or equal to 3 mm is generally considered abnormal. Okay, so this nuchal fold thickness is a second trimester soft marker, right? It is not diagnostic, it is not cystic hygroma. All right. Identify this image. Now, this image is that of cystic hygroma. This image is that of cystic hygroma. Okay, there's a veno-lymphatic malformation. So this is basically, it is much larger in size. It will look like nuchal translucency being markedly raised. Okay, it will look like as if there's a nuchal translucency being markedly raised. The idea is that it is much larger and there it is septated. It is septated. There's septa inside. It is septated. Okay, so this will be look like markedly raised NT septated sac. It will be a septated sac. Okay. So when detected in the first trimester, this is also a major anomaly. When detected in first trimester, there is increased risk of aneuploidies, serious anomalies, particularly hypoplastic left heart. And when detected in the second trimester, it can be associated most commonly with monosomy X, right? So again, this cystic hygroma, a major malformation carrying high risk of underlying aneuploidy. Now, what is being assessed here? What is being assessed here in this image? If the calipers are placed here, if the calipers are placed here connected by a dotted yellow line and they're pointing towards that, this is the most accurate parameter for gestational age estimation. Earlier done the better, done in the first trimester. This is crown rump length. This is crown rump length CRL. Good. Next question. Now I have procedure based questions curated for you. Okay, so that we can revise important pointers about the procedure. So A, identify the procedure. See, now see, I want you to remember why this procedure was done based on the stem, and I want you to remember key aspects about this procedure. It's a procedure is being done at 16 weeks, advised amniocentesis that is being mentioned because of high risk result on Down syndrome. So she must have undergone a screening, let's say in the second trimester. Maybe they could give a stem that, you know, she had high risk on quadruple testing. Quadruple testing is done between 15 to 20 weeks, right? So screening positive has to be confirmed with invasive fetal testing, isn't it? To make the confirmation of the diagnosis of aneuploidy or not. Regarding this procedure, which statement is correct? You can see it is being done under ultrasound guidance, right? From a Liker pocket, clear of the fetus. Of course, you want to take amniotic fluid sample. From amniotic fluid, the cells that are suspended in the amniotic fluid, they are extracted and they are analyzed. Okay, so fetal gut epithelial cells, fetal squames, and fetal amniocytes, these are the cells that are lying suspended in the amniotic fluid. Those cells are extracted, cultured, and then karyotypic analysis and genetic analysis can be done on that fetal cell, on that fetal tissue. That is the idea. But I don't have to prick the fetus for that. Right. So Liker pocket, clear of the fetus, that is the correct statement. That is true. It is best performed before 15 weeks. No. It is performed after 15 weeks. It can be done anytime after 15 weeks, as and when the indication or the reason to perform amniocentesis will arise during pregnancy. Okay. Now, for the context of identification of Down syndrome and aneuploidies and everything, yes, 15 to 20 weeks, especially 16 to 18 weeks is a reasonably good time to do. Why? Because the cells that are cultured, the report of these, they come, the karyotype from cultured cells, it will take about 7 to 10 days. And in our clinical contexts, it may take much longer also for the report to come back, and we want to do it safely within the legal thresholds of performing safe abortion, right? That is the idea why it's best done between 16 to 18 weeks, right? Now, the needle is deliberately passed through placenta. No, I don't want to prick the placenta. I prick the placenta, I cause bleeding. No, I don't want to do that. Anti-D is not required in Rh negative if she is ICT negative. No. In case, if there is an Rh negative woman, she is not yet sensitized, ICT negative, and for some reason I have to do this procedure in her, I'll have to cover. Sensitizing events have to be covered irrespective of whether or not I will give at 28 weeks, irrespective of the one that I will give at 28 weeks, right? So I will give it. Even in this, even in chorionic villus sampling. So these are all sensitizing procedures. They have to be covered. So this is not true. Okay? Fine? Clear? Now, let's have a look at the next image. Okay, in the next image, what you are seeing? You are seeing that there is a catheter being introduced to the cervix and sampling is being taken from the placenta, right? Placenta mein what is there? Chorionic villi, right? So this is chorionic villus sampling, okay? There are two ways to do it. There's a transcervical approach. There's also a transabdominal approach. So this is transcervical, but transabdominal approach is also there. In transabdominal approach, again, there will be a needle that will be poking into the placenta. So see where the needle is going, okay? If the needle is going into the placenta, then this is chorionic villus sampling, chorionic villus sampling, right? So now supposing if I have a situation where I have to make a genetic diagnosis, where I have to check fetal karyotype, right? And I happen to identify the woman in the first trimester, then the invasive fetal testing option that I have is chorionic villus sampling, not amniocentesis, okay? So this timing is between 11 to 14 weeks. Yes, remember that. Okay, and sample I've already told you is from the chorionic villi. In the chorionic villi, we have trophoblasts, and it is the trophoblasts that are, are analyzed basically. Trophoblast cells that are analyzed. Okay, fine. Yes, Debankita, yes, before 10 weeks. Before 10 weeks, it is not, before 10 weeks, it is not done because of the timing is actually 10 to 14. Before 10 weeks, it is not done because of limb reduction defects. You are right. Definitely not before 10 weeks. Limb reduction defects risk. Okay. Now, next ultrasound spotters. Next set of ultrasound spotters. All right. Classic. These they need no stem. You light off kar dena please sir ke upar wali. Okay, these need no stem. What is this here? The first Yes, in the first we have the lemon sign. Below that we have the banana sign, the curved cerebellum. They are basically associated with both of them. Both of them star mark, associated with spina bifida. Yes. Okay. So basically what they are is they are basically signs of Arnold-Chiari malformation which happen with spina bifida. Okay. So that is one thing. Then this one here, spotter, image spotter. This is anencephaly. Anencephaly. Okay. In this image you are seeing the eyes. Again, you have to see, you have to know what to look for. There is no fetal skull. There is no fetal skull. So eyes are protruding out. So this is what we call as the frog eye sign. This is what we call as also the Mickey Mouse head. Mickey Mouse head. Okay. Now, a clue that could be there clinical. You know, when the sonologist is doing the scan, and this anencephaly is one anomaly which can be picked up in the first trimester scan also. So imagine the sonologist is doing the scan at the patient is 10 weeks pregnant or 10 to 14 weeks, around that time he may be doing this first trimester scan, and during that time he should see the biparietal diameter. He should see this head, he should see this biparietal diameter, he should see this head, he should see that transverse plane of biparietal diameter. And he's not able to localize it. He's probing. He's not seeing. And then it strikes him. It's not there, maybe. And then he'll start looking for frog eye sign and Mickey Mouse sign and then click these beautiful images for us, right? So clue, unable to see or visualize the biparietal diameter, right? And obviously additional clues, right? Additional clues, obviously polyhydramnios. Additional clues could be there is polyhydramnios, right? But not in early pregnancy, no, not so soon. Maybe later it will develop eventually, yes. And this here image below, this one here is a bulge or swelling here, which is in the scalp region, in the head region. This is encephalocele. This is encephalocele, right? So these are all with the reds, neural tube defects. With the reds, these are all neural tube defects. All stars. Okay, here image again, we are seeing again us image where we are seeing the scalp, and around the scalp there is this halo sign, Buddha sign, halo sign. Yes, this is Buddha sign, also called as halo sign, associated with, where do you see it? Where do you see it? Fetal hydrops. Very good. Fetal hydrops. You see this in fetal hydrops. And then another scan image where you are seeing the scalp. Another scan image where you're seeing the scalp, but here you are appreciating this overriding of skull bones. Overriding of skull bones. This is seen where and what is the name sign? Very good. Spalding sign, very good, Spalding sign, which is seen with IUD. Basically, it is a sign of maceration. If I see this, I know that it is a macerated dead baby. It's definitely not a fresh dead baby. Okay, this is definitely macerated. That's why there is overriding of skull bones, right? Next, ultrasound spotter. Next, ultrasound spotter. Very classic, straightforward, but I could give you clues. So clues could be, let's say, antenatal scan was being done, there is polyhydramnios. Clue could be antenatal scan being done, there is oligohydramnios, and these are the fetal scan findings. Yes, tell me. Excellent, yes. So they could be clinical clues. Yes, we also have Robert's sign. You are right. Robert's sign is gas in the chambers of the heart, gas in the aorta, and it is a very subtle sign which is of, I have not seen any image for it. It is for theory purposes. Okay. The important thing is maceration. Because it is, I'll tell you why this documentation of maceration is important, because then you know it's for medical legal reasons, yeah. Then you know that the baby died long ago, and you know it's for that reason, Baba, that you know that if I have a macerated stillbirth, I have documented on scan, then it has a medical legal repercussions. Okay, timing of death of the baby. All right. Now, yes, you are answering here. This is duodenal atresia. Yes, very good. This is double bubble sign. Okay, and this is posterior urethral valve, because this is the keyhole sign. Okay, this is the dilated urinary bladder and the urethra of the baby. Okay, fine. Yes. Now, another clinical tidbit. When I see a duodenal atresia scan, okay, when I see a fetal scan showing duodenal atresia, then one thing that comes to my mind is trisomy 21 and its association with duodenal atresia. See, Down syndrome affected fetuses, the most common congenital malformation we see in Down syndrome affected fetuses or Down syndrome affected babies is cardiac defects. And in the cardiac defects, it is endocardial cushion defect, something that you must be reading in pediatrics. But antenatally, when I see a duodenal atresia, it's very specific. Okay, then I start thinking possibility of Down syndrome. So please understand the difference between what's specific and what's most common. It doesn't mean the same thing. Okay. Now, next image / video based question. 32-year-old multiparous, 2 previous cesareans, that's your clue. Scanned at 32 weeks, placenta anterior, low lying, overlying the cesarean scar. So that's why you see this bladder in front. This is the bladder in front, right? And what you can appreciate again, now see, if you don't have the clinical profile, if you don't make sense of the clinical profile, you will not know what to look for. It's not simply a low-lying placenta. It's not just a plain previa. Previa alone is not the answer, right? She has 2 previous cesareans, and now I become cautious for the possibility of morbidly errant placenta, and now I know what to look for. This vascularity between the bladder and the uterine serosa, right? Then this loss of this hypoechoic zone behind the placenta. Then inside the substance of the placenta, these empty spaces, these placental lakes and lacunae, right? So this will all be missed if I don't know that this is what I want to look for. Right, so like just taking it slowly, I'm kind of moving this, right? So, right, placental lakes, empty placenta, these are placental lakes and lacuna. So this is morbid adherent placenta. This is placenta accreta spectrum. Okay, and obviously it is not fitting into the profile of either of the other 2 diagnoses, right? So yes, you are right, management always a cesarean section, but please remember, management by cesarean section here, this is in a tertiary care center. Please also remember, I asked you the question on ultrasound image, because ultrasound with Doppler is the initial investigation of choice. Keep that in mind, okay? MRI is needed for further evaluation, for maybe surgical planning, or when the ultrasound is inconclusive. Then MRI has a value, and ideally operated in tertiary care centers. Multidisciplinary care is possible. Gynae person is there, surgeon is there, everybody is there, right? High risk cases these are, right? So elective delivery, elective cesarean section, that is done. You can see here, this is the, again, these are also placenta accreta spectrum images. Placenta accreta spectrum images. Okay, from the image on the left, I can see that it has almost reached up to the serosa. Okay, however, this, whether it is increta, how much deeper into the myometrium, whether it is accreta and all that, all that extra information is gained on MRI. And also after the hysterectomy is done, then the hysterectomy specimen will also ultimately corroborate the MRI findings, and we will have a final diagnosis after the hysterectomy specimen, right? So the standard of care is to deliver by cesarean section, elective between 34 to 37 weeks, okay? Elective between 34 to 37 weeks. Okay, and to proceed with, do not remove the placenta and proceed with cesarean hysterectomy in the same sitting. That is the standard of care, right? And it is not always a classical cesarean section, right? The incision has to be away from the placenta. It is not supposed to cut through the placenta. Of course, when the placenta is anterior like this, then we'll have no choice but to give it on the upper segment, right? Like this is here, it has been given in the upper segment. But supposing that the placenta is posterior and the anterior portion of the uterus is, there's no placenta there, then you can approach anteriorly lower also. So what is the issue, right? So the idea is that it has to be away from the placenta. It does not have to cut through the placenta. Now, Dhanush, it is 3D USG better or MRI? See, initial is ultrasound with color Doppler, okay, and 3D recreation of these images is not required, okay. It's not, see, please stop thinking of stop thinking of 3D USG or these things in a as a different investigation, you know. When the sonologist is going to start with this initial start with the scanning, it is going to be a grayscale. Yes, if he needs any 3D recreation for a purpose, he will do it, right? So like 3D USG is when I want to see the contours of the uterus or contours of the lesion. So yes, but here most of the time grayscale, initial grayscale, color Doppler should be enough, and then yes, if further investigation needed, MRI. Okay. Next question. 28-year-old female complains with this mass descending per vagina. There's discomfort and back pain aggravated by long hours of standing. That's a profile. But if you look at the image, you can see that there is third-degree uterocervical descent with supravaginal elongation of the cervix. So this is the anterior vaginal wall that is prolapsed out. Along with that, the cervix is also out, posterior vaginal wall is also out, right? And if I'll hold this mass in my hand, this is all the cervix, the uterus is still inside. That is why they are mentioning third degree uterocervical descent with supravaginal elongation. So fundus is not out, okay? Which of these is the most acceptable management option for her, for this particular patient, from among the 4 options given? So Kegel's exercises, for minor degrees of prolapse, maybe Kegel's can have help as a preventive measure, but not here now, right? It is Fothergill's repair, right? Fothergill's repair. She is young. I don't want to sacrifice the uterus, out of the question, all right? And the other thing is that I can go for this Fothergill's repair, which is also called as Manchester, is the same thing. Manchester surgery, Fothergill repair is the same thing. I can pick this for this particular patient because she's Paris. Okay, so this can be an option only for those who are not wanting to get pregnant. Okay, this is an option for those not wishing pregnancy in the future, because it will involve amputation of the cervix, all right? Vaginal hysterectomy, of course, out, and Lefort's repair is a procedure where the anterior and posterior walls of the vagina are closed. So it cannot be, Lefort repair can be an option only in postmenopausal women who are not going to menstruate, okay, because we are closing the vagina, of course, right? So keep that in mind. So old age who are otherwise not good surgical candidates, in whom maybe a major vaginal hysterectomy cannot be done, right, who are not good surgical candidates, there we can go for Lefort's, but then they have to be postmenopausal, and we have to also tell them that, you know, that they cannot be sexually active then anymore, okay? And so that will be one issue, and the other issue will be that the cervix we have put inside, no, we have replaced inside, we have not removed the uterus in Lefort's repair. So ideally, we should also ensure that, make sure there is no intrauterine or cervical pathology that we are missing, because then in the future, the access is blocked. Now, we can't approach the cervix or uterus for any evaluation in these women if they go for Lefort's repair, right? So that is the thing. No, Lefort's repair is not obsolete, yaar. It is not obsolete. Certain circumstances, one may go for Lefort's repair. ऐसा नहीं है that it is obsolete. It will depend upon the patient circumstances, the surgeon's expertise and the facilities available. So that is why if in MCQs they will give you, most of the time if they are asking about the management, please cater the management to the patient. Okay? Right? Hysterectomy in which cases? Postmenopausal. Vaginal hysterectomy with pelvic floor repair. Postmenopausal. Fit for surgery. Okay, uterus preserving option. The best uterus preserving option. The best uterus preserving option. The best meaning best outcome. Best surgical outcome, best uterus preserving option. Also applicable for nulliparous woman. Sacrohysteropexy. Okay, sacrohysteropexy. The mesh surgeries. And yes, there are sling procedures also. Slings, like the different sling procedures using sometimes Merceline tape, sometimes autologous graft material. So sling surgeries are also described. But this would be giving the best outcome. Best uterus preserving option will be sacrohysteropexy. Okay. Now, when you say sacrocolpopexy, this is sacrocolpopexy. Okay. I'll just come to this image later, a little later. Identify these images. This is also third degree uterocervical descent. Okay. When I say third degree, that means the cervix is outside the introitus and the fundus is, the uterine fundus is still inside. Okay, keep that in mind. Okay, so from the image, I can only say this is third degree descent most likely. Whether it is procedentia or not, extra information is needed. For procedentia, the extra information that should be there is whether the fundus is outside or not. That would be procedentia. Or complete eversion of the uterine, complete eversion of the vaginal wall. These will be the extra pointers for procedentia or fourth degree. Okay, so based on the image, I can say this is at least a third degree uterocervical descent. But yes, movie masala, this is what I wanted to show you in this image. I wanted to show you this finding. This is the decubitus ulcer. This is the decubitus ulcer. This ulcer should be healed before attempting any surgery. So this is a woman, this is a postmenopausal woman and she had a decubitus ulcer. I want to plan her for a vaginal hysterectomy and pelvic floor repair. But before that, I want to heal the tissues. This is a venous congestion ulcer. I want to heal the tissues first, howsoever time it may take, right? So it generally takes about 15 to 20 days of packing, right? So glycerin and acreflavin vaginal packing needs to be done. Okay. Tissues need to heal because I am going to do surgery, I am going to do dissection. I want the tissues to be more supple. Here the tissues, this is the venous congestion ulcer, so tissues vascularity is congested, right? Dissection is difficult, so that is why I want good surgical outcomes and I want my repairs to be better. That is the reason. Okay, image on the right, image on the right. You're seeing a bulge and you see now this is just up till the introitus. This is just up till the introitus. It is not coming out of the introitus, right? So this is grade 2, whatever it is. But what is it? What is it? I have to give you clues. Clues is, clue number 1, she is having complaint of stress urinary incontinence. Clue number 2, a bulge is coming out, seen coming out, bulge seen coming out from anterior vaginal wall. Okay. है ना? So these are your clinical clues, and this is not an imperforate hymen. Sorry, this is not an imperforate hymen. Na, wo to image will come with context. Okay, this is the bulge coming out of the, and this is the anterior vaginal wall bulging out. You will ask the woman to cough, it will bulge even more. Cough impulse is present. Right? Cystocele. Yes. So now with the profile, we know cystocele. Okay? Fine. Now look at this image. In this image, we are seeing that there is a mesh, okay, and it has been placed on the vagina. There is no uterus, okay. So same principle also same. Sometimes like when I said sacrohysteropexy, there will be a uterus here. But here the uterus is not there. This is sacrocolpopexy. This is sacrocolpopexy. And this is for vault prolapse. This is surgery for vault prolapse. This surgery for vault prolapse is the one that gives best outcomes. Okay. And if you look at the image on the right, the two images on the right, okay, what are these images telling you and what's the procedure? Yes, you will see that there is the tape and you will see that it is being, a needle is being introduced from below the urethra, a needle from below the urethra, right? And you will see in this image on the left, it is coming out from the obturator foramen. This is transobturator tape. Here you see that it is going in the space of radius. If it is going behind the pubic bone, in the space of radius, this is transvaginal tape. Tape through space of radius. And this you will see from the obturator foramen. Okay, these are mid-urethral slings. Both of these are mid-urethral slings. Both are these mid-urethral slings, and these are the procedure of choice nowadays for SUI. Good. Next question. Appreciate the small clip, and this is a procedure which is being undertaken for lawful termination of pregnancy. She is 8 weeks. So this procedure is allowed till 8 weeks. Vital signs are stable. Regarding the technique of the procedure, which statement is correct? Which statement is correct? Yes. A and D, absolutely different answer. B, D, correct statement, correct statement, correct statement, correct statement. See, now see, please understand, and again, now this is a procedure that we expect undergraduate students to have seen. It's very common. MTP is being done, suction evacuations being performed for a variety of reasons. Suction evacuation for first trimester, MTP it is allowed till 12 weeks, right? Or suction evacuation being done for molar pregnancy, or suction evacuation for incomplete abortion, or whatever. So it is a very commonly done procedure, and it is expected that you see, right? Now, bimanual examination will proceed. Your examination will always precede any intervention, Baba. Nahi. It will, like you want to introduce instruments inside the uterus, you want to know the size of the uterus or no, or directly put the patient on the table and directly start introducing instruments. Make sure that she is 8 weeks, no? What if the uterus is much bigger in size? Then you will wonder, oh, you know, it is a big pregnancy. How will I do suction evacuation, right? So clinical examination, confirmation of the gestational age, very, very important. Is she even fit? Legally, I have to do it within the right time frame, right? So up till 12 weeks it is allowed, that thing, right? And I also want to know by clinical judgment. By clinical judgment, we also assess. That is why we do bimanual examination, right? So you must have read about uterine sound. You must have read about this instrument called as uterine sound for sounding the uterus and measuring the uterocervical length and measuring the size of the uterus, right? Like that. Pregnant patients में generally we are not doing it. Okay, it's fine, ठीक है, sounding of the uterus, if somebody wants, they can do, it's not contraindicated in a pregnant uterus, but generally we are not doing, and most of the times if you have witnessed, then your seniors are not sounding the uterus at this point in time. Okay, they are doing a bimanual PV examination and they are making a clinical judgment. It seems like 6-week size uterus or 8-week size or 10-week size uterus, like that. It is a clinical judgment. Okay, so the procedure is suction and evacuation. How do I know the procedure is suction and evacuation? I see a cannula being introduced inside the cervix, and I see the uterine cavity being suctioned out, and the profile that it is being done at 8 weeks, right, for a lawful termination of pregnancy. This is suction and evacuation, right? Electric vacuum aspiration we are doing actually in this this thing, because the suction apparatus is connected. This is the Carman's cannula. This is the Carman's cannula, and this is connected to the electric vacuum in the electric suction machine, right? It is connected to that. So where was I? Bimanual examination first. Okay, I will know the size of the uterus, because I will not use whatever largest cannula is available. I will use the size of the cannula used will correspond to the size of the uterus. That is basically the gestational age. That is what I was saying, no, whether it is a 6-week size uterus or 8-week size uterus, 10-week size uterus, clinical judgment. Right? So it will decide for me how much I want to dilate, with which dilator I want to dilate, how much, what size Carman cannula I want to use, right? So bimanual examination first, then cervical dilatation, then cannula insertion, cannula introduced, then attach the suction, then ask the suction machine to be on. Okay, then complete the procedure, then ask to close off the suction, and then take out the suction cannula. So during insertion, during removal, suction is off. Okay, so suction is applied not before, but suction is applied to the cannula before it is introduced into the uterus. That is wrong. After it is introduced into the uterus and before taking out. So during insertion, during removal of cannula, suction is off. Okay, so this is wrong. All right, now once I was doing the procedure, I'm looking for clinical signs of completion. Okay, I will see what products are coming out. I will see those products filling my cannula, right, and going into the suction machine. Then I will see, okay, now products are no longer coming out. There is this uterus shrinking in size, it is gripping my cannula. There is a grating sensation that I am feeling. This is all about feel. I can't show it to you. Sorry, you'll have to take my word for it, okay? There is a gripping sensation, there is a grating sensation, right? And only air bubbles are coming out, no more products are coming out. I'll say the process is completed, right? You may have seen people doing check curettage routinely after this. It's not mandatory, it's not needed, it is just additional extra step. Unnecessary, absolutely, right? So following completion of procedure, a check curettage is always done? No. Right? So this is the answer to this question is option number A. All right. Now there is a liquid-based cytology clip being shown to you, right? Liquid-based cytology shown to you. She is not menstruating, has no vaginal medication being used, and sample is being collected. What is the incorrect statement? Hi, it will end before the micro LRR. Yes, yes, it will end. It will end much before. It will end in another half an hour at the most. It will end, Baba. Yes, which statement is incorrect? I will not overlap this with your micro thing. I am well aware of that. Okay. Yes. So incorrect statement is option number D. Again, undergraduate students, pap smear, not, please remember, we want to assess whether these are very basic procedures And these are the clinical aspects that I think the examiners would want to test, right? Whether you know how pap smear is taken. Okay, so the sampling device is rinsed and detached, and it can be detached and put into the liquid fixative. So this is the correct statement. This is true. And avoid per vaginal examination. Obviously, why will I do a PV first? I will avoid betadine, I will avoid any cleaning, I would avoid doing a PV. I put in a speculum, note the findings, and I take the sample. Okay, because of the cell yield, right? I want to sample this surface. That is where I want to take the sample from. Why will I do a PV and, you know, what kind of cell yield will I get? Okay, so avoid PV before taking the sample. This is also true, right? So same sample can be used for HPV testing. That is the advantage of liquid-based cytology. The same sample that I will send to the lab now, that bottle, that fixative bottle in which I have put in the sample, that same sample can be used for HPV testing. True. And any lubricant gel, nothing, that is not, absolutely not done, okay, to improve the cell yield. Next, I want you to see the video and identify the procedure being performed. Again, a procedure that we do in the OPD. So this is procedure that I'm doing. This procedure is from, you won't believe, this is from my thesis days. So years ago I did, and I found it. A 35-year-old woman, para 2, with a pap smear report of HICIL undergoing colposcopy, identify the procedure being performed, right? I will take you through. Now, this is what we do in a colposcopy, and you see that I can do this now. I'm taking the advantage of colposcopy that we had, and we did this procedure, guided procedure, okay? And this is the closest image I could get for you people, because again, I record, I had this from days when I was not teaching. So I've done what I could with this image. So you can see here, there is a white area, but that white area is going inside the endocervical canal. Okay, there's a very faint white area which is going inside the endocervical canal. Right? If it was obvious on the outside, I would have taken the sample there itself. Then when I applied the Lugol's iodine, I see this yellow. It is not taking up the iodine. So I know this is an abnormal area. This is a Paris woman, right? She had a high grade report. So what we did for her was a leap. In the same sitting, HICIL is a very specific bad report, no? Isn't it? So what we did was we removed the transformation zone, also because the area was going inside. A little bit the area was going inside. So what we did, we took the sample. So we had the transformation zone removed and we sent it for histopath. After histopath, the final report came CIN3, CIN3, and the margins of the specimen were free. So she was diagnostic therapeutic at the same sitting. This is the advantage of a procedure like LEAP. You see that there's no bleeding that happened during the procedure. The patient does not need to go into the OT and undergo any anesthesia. It can be done under local anesthesia, and also sedation, mild sedation can be used, okay, to calm the patient, right? So this procedure being performed is LEAP. This is treatment of choice for CIN 2 or 3, high grade, CIN, HICIL. Again, the clinical context where we do is important. The clinical context we do is important. Okay, fine. Now, what to do if not satisfactory colpo? If there's a high grade report and colposcopy is unsatisfactory, one would also go for endocervical curettage. One would also go for an endocervical curettage, right? Like in this patient, we took that specimen at the end of the procedure. We did an endocervical curettage also for her. Okay, so just to give you a perspective. All right, fine. Now, next procedure. Look at this video, small clip. It is showing you hysteroscopic resection of a submucous fibroid being planned in the early proliferative phase. Most of the gynae surgeries which we are going to do, right, are going to be planned post-menstrually. The video shows the energy system in use. You have to tell me which distension media is used. So the clue to this question comes from two things. One, it is a hysteroscopic resection. Second, if you could possibly identify the instrument. Okay, if you could possibly identify the instrument. Yes, so this is showing a monopolar resectoscope. It's a monopolar device. Okay, monopolar device. So that is why I know that this, and I was getting very clear images. Clarity is not much of an issue, but the main idea is, please remember, monopolar. So with that logic, yes, the distension media used is glycine, because this is electrolyte free media, and it is only in this media where we can use monopolar instruments. The other is normal saline. Other media is normal saline. So mainly when we are doing operative procedures, for operative procedures, we are mainly preferring glycine. It allows us to use these monopolar instruments. Normal saline, we can use only bipolar instruments. Okay, so that is the thing. All right, and among the two medias, the risk of fluid overload complications is more with glycine as compared to normal saline media. But generally, when we are operating the patient, we are taking care. Fluid in, fluid out, we are measuring. Okay, we are taking a note of how much is the fluid deficit. We are monitoring the patient. So fluid overload complications, we generally don't see until unless the surgery has been very prolonged or some complication has happened. So most of the times we are on the safer side, right? What I need you to remember for your instruments for your exams is monopolar. I want you to look at this image where it is a monopolar instrument. Okay, so monopolar, this is so what happens is, this resectoscope is that it vibrates with electricity, just like the loop vibrates, cuts the tissue, cuts and coagulates at the same time. Monopolar, right? Principles of electrosurgery I cannot be teaching you here right now. Bipolar instruments will have, when you bipolar instruments are bipolar cautery, try to compare with that, na? Two flanges, bipolar cautery, tissue has to be held in between the two flange cautery. That is bipolar. This is monopolar. Okay, I like chopsticks. Thank you for that description. Yes. Okay. Next set of images. Again, this is just for your identification. This is hysteroscopic view. If you were not able to see in the previous image, this is hysteroscopic view of the fibroid. This is submucous fibroid. This one here and this one here. I have to see both reports. I saw this report first, okay, and then I saw this finding. Okay, I saw this finding, and then of course I was planning for a surgery, so we did this procedure. Hysteroscopic myomectomy for FIGO type 1 and type 0. This one is type 0. This was completely intracavitary. Of course, I have to see both the reports, okay. How much is it in going into the myometrium? I will need ultrasound for that. Right? So this is submucous. In this particular image, this is type 0, this is intracavitary. Okay, this one here, see how much of the fibroid is inside the myometrium. I have to see on scan, right? So see this outline of the uterus, outline of the uterine cavity. This one here is intramural. This is intramural fibroid. Okay, this one is intramural fibroid, and just for comparison purposes, fibroid is going to be hypoechoic as compared to the surrounding myometrium, and heterogeneous also, and has peripheral vascularity, as we can see in this image. right? Compare this with this. This is, and the clinical context may be different, right? This is inside the cavity, a hyperechoic lesion. It is under that yellow bracket because Doppler is being used. Can you see? This is the outline of the uterus. So this is hyperechoic. It is whiter, hyperechoic than the surrounding myometrium, and it has this feeding vessel sign, right? So this is yes, endometrial polyp. This is endometrial polyp, and these are the findings on hysteroscopy for this patient. Hysteroscopy, right? We did a hysteroscopic polypectomy. Polyp was removed and sent for histopath. Diagnosis was confirmed. So, and they typically cause intermenstrual bleeding. They can cause any pattern of abnormal bleeding, but most typically associated with intermenstrual bleeding. And so symptomatic patients, or if there is an endometrial polyp associated with infertility, it is generally removed. Okay. Next, identify the procedure. This woman is undergoing tubal sterilization. I want you to just look at the small clip. And this person is undergoing tubal sterilization via mini laparotomy. Okay. Identify the procedure. You see a loop is being created of the fallopian tube. Then it is tied and it is cut. And we are in the habit of taking an additional extra suture below that, just tying for additional strength. And then the loop is cut. And then this fallopian tube is put back inside. Okay, what is this? Now, after 6 weeks only mini lap, not at immediately after delivery. No, I can do it after delivery also. It's not crushed. You may have seen crushing being done, but crushing is something, again, there are different ideas to it. Crushing or not crushing, the idea is that crushing is going to the cut ends of the loop. If they are crushed, it causes ischemia. Wherever ischemia happens, then it causes chances of reanastomosis. So crushing is something that we tend to avoid. All right. This is, nobody answered. Yes, it is modified pomerois. Yes, this is modified pomerois. Okay. And this, the modification is the Pomeroy made a loop. He said make a loop and cut and everything. The modified one that we are doing is, the modification is that we are using plain catgut suture. We are using plain catgut suture, which is rapidly absorbable. Not just absorbable, rapidly absorbable. Idea is that absorbable suture, you see, it was in the video only. I will show you. In the video, if you look, that these cut ends, they were very close together. These cut ends were very close together before I will put them inside it. Idea is, as the suture is going to get absorbed, these cut ends are going to get further away from each other. That is the idea. Absorbable suture used. Cut ends move apart. Cut ends move apart as the suture gets absorbed. So this is modified pomerois. Right? And crush based, you are right, is Magdalena. So the crush based we are not doing, right? And the other thing is about mini laparotomy. Let me just tell you about mini laparotomy. This patient was undergoing interval ligation. Okay, where we were doing this, where laparoscopy facilities were not available. Okay, so if interval ligation has to be done, then laparoscopically would be the best, right? It is preferable mostly. But we were doing it at a setup where laparoscopy services were not there. So we were doing a mini laparotomy for her. Okay, so ideally, yes, let's say the mini laparotomy incision, I have given here a suprapubic incision, a small 2 centimeter suprapubic incision. Supposing I have to do PPS, postpartum sterilization, then fundus is here. So just below the 2 finger breadth below the fundus I will give. The idea is that I have to find the tube. Okay, I cannot, so accordingly, if the fundus is here, if the uterine fundus is here, then I will not give the incision so down below. Mini laparotomy is a small incision on the abdomen. That's what's mini about it. Okay, so where I give the incision is another matter, right? Yes, mini laparotomy can be done as early as, yes, it can be done within, yeah, it can be done. Yes, it can be done. As early as on the next day we can do it. Delivery, after that generally we plan, if the patient is in the ward itself, we plan for the next day. Yes, we can do it. We can do it up till 7 days after delivery. We can do it up till 7 days after delivery. Okay. Now, next set of image spotters. Next set of image spotters. Next set of image spotters for you. Clinical profile important. Clinical profile, that of recurrent pregnancy loss, recurrent preterm births or second trimester pregnancy losses. But please remember second trimester, mainly second trimester. So first loss, let's say, happened at 6 months, then 5 months, that 4 months. Like that sort of a history. And painless, spontaneous, sudden expulsion of the fetus. They can ask you image, they can give it with an image. Okay, so this is normal on the left side. They can give with an image, they can give with a profile, and they can ask you what is the diagnosis. What is the diagnosis? Cervical insufficiency. What we are seeing, history is very important. Diagnosis begins with history, not isolated finding, not isolated ultrasound finding. Okay, fine. So transvaginal sonography में क्या देखना है? Transcervical length. We have to see the cervical length of the closed cervix. This closed cervical length we have to see. In this image we are seeing the funneling also. In this image we are seeing the funneling also. So this is what we describe, no? T-shaped cervix, internal os starts to open up, V-shape, Y-shaped cervix, V-shaped cervix, U-shaped cervix. Idea is that as the cervical length will continue to shorten, these appearances on ultrasound will come. Okay, so it is the length of the cervix which we have to see. So this is T-shaped. So length of the cervix. So cervical length less than 25 mm between 16 to 24 weeks. This is what we monitor for. Okay, in a patient who has a classical history. Okay, now please make a note, contraindications to cerclage also. If I'm going to use cerclage, then uterine contractions, vaginal bleeding should not be there, leaking should not be there, obviously infection should not be there, membranes should not be ruptured, and obviously I want to do it for a healthy fetus. Okay, now this image is McDonald cerclage and this image is Shirodkar cerclage. Modified Shirodkar cerclage. Modified, why? Because the an incision is given in the cervix, a tape is placed. People use tape, people use sutures. It is not about tape or suture. It is about dissection in the cervix and placing it high up, able to place it high up and burying the suture, closing the incision on the cervix and then burying the suture. That is the idea of modified Shirodkar. So the tape or the suture is buried. That is the whole idea. So keep that in mind, right? And नहीं, only anterior incision नहीं है, posterior भी तो incision close किया है ना? How? Not anterior only, not only anterior, posterior incision also. It's not anterior, it's posterior incision also. Posterior also. Okay? Right? So remember this. Now other thing that I want you to remember, clinical tidbit about the timing of the procedure. Timing of the procedure. See, if we are doing history indicated, sometimes we can do history indicated when there is 3 or more than 3 pregnancy losses and the diagnosis is that of cervical insufficiency based on history alone. Such high risk based on history alone. More than or equal to 3 recurrent pregnancy losses due to cervical insufficiency. History is very classical. Then timing is between 12 to 14 weeks, best. And when we do ultrasound indicated, then best before 24 weeks. Okay, keep that in mind. Alright, difference किसमें समझ नहीं आया? Shinchan. In the left on McDonald's and versus Shirodkar's, McDonald's you are seeing that there is no dissection done on the cervix, purse string sutures are taken. Shirodkar's, there is a dissection in the cervix. Okay, in this image, this is a classic textbook image. Okay, dissection is done in the cervix and a tape or a suture is placed. It could be a tape, it could be a suture. The idea is dissection done on the cervix and then the cervical mucosa. It is a submucosa, okay, that is closed then and the tape is buried. Now I have forgotten how many slides I have put. I think only last bit is left. Identify image. Vishal, like I said, it is not about the tape. Okay, I've repeated it. Please, you can rewind it and then read it. Listen to what I've said. Identify the image. Yes. So yes, it could be a physiological spasm. I don't know for sure right now, but all I can know from this HSB spotter is that it's bilateral corneal block. That is what I know. It could be physiological spasm. I don't know, or it could be true. Okay, this is bilateral distal tubal block, possibly hydrosalpinx. Okay, next step will help me make the diagnosis. What is the next step? Yes, chromoperturbation. Next step, chromoperturbation. Yes, so I will plan laparoscopic chromoperturbation. Definitely, I will do this. But I will also prefer to do it with hysteroscopy. I will prefer to do it with hysteroscopy because of the clinical context. Because in the clinical context of evaluation of infertility, evaluation of female infertility, I may be in a situation, most of the times actually we are in situations where we want to analyze the uterine lining also. So might as well do it in one sitting. Okay. Next, image-based spotters. Next, image-based spotters. Okay. Now, what sort of question comes? Either direct HSG-based spotters or HSG or the diagram, and they ask you what is the problem. What is the problem? What kind of embryological pointers will lead to this kind of a defect? Okay, so these are Mullerian anomalies when there is, and I've already marked it with arrow for your revision. Okay, incomplete failure of Mullerian ducts. When there is failure of fusion, we see a dip at the fundus. Okay, so you can see here that this is, wide angle. Okay, these are the 3D TVS images. These are the 3D TVS images. This is the investigation of choice now for Mullerian anomalies. Okay, so what are we seeing here? This is the endometrium, this is the myometrium. Just showing you here. Okay, right? So we have having two cavities and dip at the fundus. First one is bicornuate. Okay. All right. Now second one, you can see this is acute angle, and there is failure of dissolution of septum. So fusion happened fine. There is no dip at the fundus. There is septum, failure of dissolution of septum. This is septate. Complete failure of fusion, this is didelphys. How do I know this is didelphys? Because there are two shadows of cannula, that clue, or they have mentioned on per speculum examination two separate cervix. Then this one here is didelphys. Okay, this one here is unicornuate, fairly obvious, only one side Mullerian duct develops. Okay, and this image here is showing arcuate. Okay, arcuate again, cavity is more or less intact, and cavity is more or less fine, it is not distorted that much, and this septum length less than, it is a very small depression, not at the fundus here, septum length. Look at this septum length and look at this septum length. This septum length is, I'm pointing here, look at this septum length, less than 1 centimeter. Okay, just to give you perspective, otherwise arcuate kind of differentiation I will not expect from undergraduate students. This is slightly on the higher side, but yes, 3D TVS images because it is becoming more and more common, potential to be asked. Okay. Now, for rudimentary uterus, is it partial fusion? For rudimentary horn, it is the one that is developing. For rudimentary horn, it would be the other side did not develop at all. Now, uska only rudiment is left. So, it is not about fusion at all. Okay? Okay, here. Anshuman, which one is most compatible with fertility? All are compatible with fertility. All are compatible with fertility. They don't usually cause infertility. We have cases where women, they will deliver fine and probably never have an abnormal pregnancy outcome. But again, we cannot predict which ones are those who will suffer from recurrent pregnancy losses, possibly second trimester pregnancy losses, and biconjugate septate are the ones which are commoner. The rest are anyways rare. So septate is the most common. All right. So septate uterus, they can be associated with recurrent pregnancy losses. Biconjugate uterus can be expected. So it depends, right? So they don't generally present with infertility, but septate uterus is one anomaly which can contribute to infertility possibly, right? That's why surgical correction is not done for incidental diagnosis. Like I said, we can't predict who will have a bad outcome. Right? So that is why surgical correction is not done for incidental diagnosis. Surgical correction for septate uterus definitely has a potential advantage. But if there is history of recurrent pregnancy loss or there is infertility, then if in those cases we have septate uterus, then hysteroscopic septum resection. Okay? And surgical correction of biconjugate uteruses and other rare anomalies are again, these are again, case-to-case basis we decide. It's not necessary that we always treat a biconjugate uterus surgically. Okay? Right. Now, next question. Identify with this clip. So, this is to give you a perspective as to these sort of questions possibly I thought that could be, intraoperative findings could be asked, right? So, firm abdominopelvic lump with pressured symptoms, right? Underwent a total abdominal hysterectomy. These are the intraoperative findings. Gross is most consistent with the diagnosis of yes. What is this gross diagnosis of? Yes. Anybody now change after seeing the full video? Anybody changing the diagnosis? It is A. Right, you can see this irregularly enlarged uterus, okay? And then I was showing you the cut section also. This is fresh, this is the cavity distorted, and this is a subserosal fibroid. On cut section, there is a pseudocapsule. On cut section, there is this whorled appearance. This is leiomyoma. It's not a submucous fibroid. Let me show you again. This is the cavity. This is the cavity. Not much distortion of the cut section of the cavity. And this is the fibroid that we're cutting, arising from the subserosal. Look at this again. Much of the fibroid bulk is subserosal. Subserosal and intramural. Partly subserosal, partly intramural. Okay, fine. Now, next image. This is your adenomyosis. This is the gross. These are freshly cut in, freshly. I always have this habit of, doing the, and I think if you have seen in the OT, the cut section of the specimen is done in the OT itself. I mean, otherwise, the pathologist will do it and then they will do it in the formalin and this thing. So we were seeing here, cut section, right? So this is adenomyosis now. There's no tumor like that. There's no definitive pseudocapsule like that. There's just thickened myometrium. So this is adenomyosis. Two things I want you to remember, right? This is the image showing myometrial cysts. This is an actual image of this patient's scan. Okay. Initial investigation of choice, transvaginal sonography, good enough. In this image, we are seeing Venetian blind appearance. Okay, this acoustic shadowing that we see, right? Like the rays of the sun, like the fan-shaped acoustic shadowing, that is Venetian blind appearance, fan-shaped acoustic shadowing posteriorly. This is the classic MRI image of adenomyosis. MRI not always needed. MRI done if ultrasound is inconclusive. All right, that is MRI helps. Not always needed to make the diagnosis of adenomyosis. Nowadays, your 3D, nowadays your transvaginal sonography, will be able to make the diagnosis of adenomyosis also in most cases. So what we are seeing here, the myometrial is the empty black spaces, the endometrial glands and stroma buried in the myometrium. Those are seen as myometrial cysts, black spaces on ultrasound. The same are looking as hyper intense signals, the whiteness, white dots you are seeing, myometrial cysts. Endometrial glands and stroma buried in the myometrium. What also we are seeing in this image is the junctional zone thickness. Junctional zone thickness. Okay, what also we are seeing here is the junctional zone thickness. Next, I have shown the images of, dermoids. I keep showing, but this is something I got fresh case, fresh dermoid cyst, dermoid I got image. So I wanted to show you this. This is this was a 40-year-old multiparous woman approximately, and she had a huge size lump, an Excel lump, ovarian mass, right? And we did basically for her, her family was complete. We did a salpingo oophorectomy for her. So this is the but dermoid we can do cystectomy, but it was so long standing dermoid na, we had a lot of, we couldn't remove the cyst only. And anyway, she was 40-year-old multiparous, right? So we decided that we are going to go ahead with so this cheesy material, look, on cut section. It was so damn heavy also, filled with cheesy material. We cleaned all that out and then we could see this Rokitansky protuberance, the teeth and the cartilage, that one solid nodule inside, the whole cyst was filled with cheesy material and hair, like a putty, like a cement, this thing paste. And these are the scan images of this particular patient. You see, this is the solid Rokitansky protuberance that we were seeing, and these are all the dash and dot appearance. So, I mean, this is so clearly we were seeing all this cheesy material and hair, that's all inside, right? And this is also what we were seeing in another plane for the scanned images, same patient's images. These solid, these are fat spherules, okay? These are fat spherules basically, these ones. So some lumpy collections of fat, this fatty tissue, somewhere it is dash and dotty. So this is dermoid. Right? So this is not Rokitansky protuberance or cystic wall with cancer. It is not cancer. It is not cancer. Teeth and cartilage, bhaiya, the teeth and cartilage. I sent it for histopath. They confirmed that it is a dermoid. It's a mature cystic teratoma they mentioned. You see? So gross examination findings important or not, right? So ultrasound, when I saw this scan, I was like, okay, it looks most likely like dermoid. Okay, then intraoperatively, we said, okay, it is looking like dermoid only most likely. And yes, intraoperatively, we had not yet cut. We have removed the whole thing. Right. So intraoperatively, the decision was simple. Na? She was multiparous, and then we removed the entire lump. We removed salpingo oophorectomy. We did the other side. We didn't touch. Only one side we did for this particular patient. Okay. See, this is the uterus. This is the other side. Ovary is normal. It was only on one side. We removed this. We removed this. We had the cut specimen, and it was dermoid. And we have the last question. Last question. If I want to discuss this question, it is not an image based question, but it is an interesting question. Okay, if you look at the PYQ of the PYQ session that we had last, okay, my last YouTube PYQ session had a question on RH negative pregnancy. I have another question on RH negative pregnancy today for you people. Anshuman, there was hair and teeth not in the uterus. It was in the ovary. It is dermoid cyst of the ovary. It is an ovarian tumor, germ cell tumor, benign, mature cystic teratoma containing the germ, all three mature elements of all three germ layers. Okay, so please just go back a little and read maybe about it. All right. Yes. So what do we have here? We have option D, C, D. CD. Okay, nobody is giving anti-D, that's okay, right? So she has come at 28 weeks. If, okay, anti-D to the mother immediately or after delivery is out because she is anyways ICT positive, and you know that now, by now you know that anti-D is given for prevention of sensitization to those who are ICT negative. Okay, so this is not the answer. Follow up with titers and MCA PSV Doppler. These are the two choices. We still have D or C. 1:16 titer. You are right that if titers cross the critical titer, then we should go for Doppler. But if you look at this profile here, her first child delivered vaginally at home is alive, healthy, that's okay. Her previous pregnancy, she had delivered an RH positive baby who had developed jaundice, was admitted to NICU but did not survive. She does not recall getting any additional injections apart from routine tetanus immunizations in any of her pregnancies. From the profile, it looks like this RH positive baby is most likely a prior affected fetus. Okay, so her first pregnancy was fine. Second pregnancy, this baby actually got jaundice, did not survive, right? And she's also not recalling getting any additional injections. This also, I had this profile because I saw a patient like this, okay, on history. So that it occurred to me that this is a question, right? So what did we do? See, then ICT positive, yeah, you could have when they come back with the ICT positive report, na, titers automatically they do and tell. The idea is when there is a prior affected pregnancy, prior affected fetus is there. When there is a prior affected fetus, from the profile it was seeming that it is a prior affected fetus, most likely. I mean, there were no papers with this patient, you know, no papers were brought. She is not aware, unbooked last 2 pregnancies, delivered somewhere. Now, in this situation, let's assume, right, that obviously with the profile, it is seeming that most likely this is a prior affected fetus. Now, in that situation where one pregnancy has already gotten affected, in the previous pregnancy only, in the last pregnancy where she had this RH positive baby who developed jaundice, did not survive, she must have become ICT positive back then only. And titers, since the baby seems to be affected, then the titers must have been crossed at that time, obviously. So now fresh titers don't matter. Okay, now fresh titers don't matter. All right. So follow up with fetal MCA PSV Doppler weekly. Okay, fine. If that sort of a profile is not there, when there is no history of prior affected fetus, no history of prior affected fetus, ICT positive for the first time, right? In those situations, yes, we can monitor the titers. And once the titers are more than or equal to 1:16, once the critical titers are crossed, then we go for PSV Doppler, right? Not doing the titers or monitoring the titers is not useful because it does not eliminate the risk. Once there is a prior affected fetus, monitoring the titer, meaning low titers, also does not eliminate the risk. I'll tell you why. Because with each successive pregnancy, what will happen that she will form more antibodies because she's already sensitized now. So titer value is not there anymore. Monitoring with titer value is not there anymore. So even if initially the titer may be low, you never know, she may suddenly start in the next subsequent pregnancy, suddenly she may have produce a lot of antibodies, and you know those antibodies will cross and affect the baby. So low titers, monitoring with titers cannot be very reassuring in that situation in case there is a history of prior affected fetus already. So follow up with MCP Doppler. Okay, if ICT negative Then what would have been the option? If ICT was negative, that means the baby who had jaundice had jaundice because of some other reason, let's assume. Then the profile would be different. I will not give you such a history where I will complicate the findings where there is a baby already dead or something. But yes, if it is an ICT negative patient, I'm seeing her maybe early pregnancy, I have confirmed that she is ICT negative, then repeat ICT again at 28 weeks. So ICT negative, repeat at 28 weeks again, ICT still negative, then we go for anti-D. This is the routine antenatal anti-D prophylaxis which is given at 28 weeks and then after delivery, after checking the baby blood group, right? Okay, so with this we can such patient have incidental ICT negative? What do you mean incidental ICT negative? ICT negative means ICT is indirect Coombs test. ICT we are checking Rh antibodies in the serum, in the maternal serum. ICT test we are doing for the mother. Okay, in the maternal serum we are checking antibodies. Okay, there is a pregnant patient, Rh negative. All the problem will be with the husband blood group is Rh positive. Husband blood group is Rh positive. Okay, mother negative, husband Rh negative, possibility of Rh positive fetus. Okay, so I do an ICT, I know if it is negative. One thing I know, she is not yet sensitized. If she is not yet sensitized, then goal is to prevent sensitization, then anti-D injection. Or ICT positive, that means she is already sensitized. Then no role of anti-D. Okay, right? Now anti-C and anti-E we are not routinely doing. We are not routinely doing anti-C, anti-E. Okay. So with this we finish off the session. These were the lot of images I had for you, right? I don't know how many of you are joining me from the LRR, because from the LRR also there were certain images that we had not done in the LRR session, so that those were covered here. Certain topics were not covered, that those were covered here. Mostly, roughly, broadly, yes, all the images are there, but then again, obs, gynae, there are many images to see, you know. But we could wrap that much up. That is, and 5:30 is done. It is, you have a session at 6, I believe, yeah. So you can take your half an hour break before you join that session, because I think micro also will be a pretty long LRR for you now. Yes. All right. Yes. All right. So for now, we are going to take a break. Okay. For now, we are going to stop this session. All right. Okay. Bache, if you were to just go through the previous LRR also. Okay, there is in the PrepLadder channel only it is there. There is a separate LRR which we did, in which gynae separate is there and OB separate is there. Separate LRR is there. Gynae separate, OB separate. 4 hours LRR, free on YouTube. In this channel only, in your PrepLadder channel only, you'll find it. It is still there. A lot of questions, a lot of recent areas, and they are all covered. Okay. And I will be sending the PDF. I will be sending the PDF. Okay. So you can find the PDF. Just a second. If done, resolve plus lap 2 for revision LRR should be enough. Yes, if you have done resolve with me. Yeah. If you have done resolve. Yes. Then it should be enough. क्वेश्चन सारे LRR से आ जाएंगे क्या? बस मुझे I cannot give that prediction. Baba, please, it is not in my hands. I am not creating the paper. I am seeing the trends. I prepare you for from the most obviously asked topics. Please read the topics, do the questions in a manner that if they ask you thoda sa ghuma phira ke, then you are able to attempt those questions. That is my idea. Nobody can tell you which questions are going to come. Sorry, I cannot give you that kind of a false hope ke ye from a 3-hour LRR session, you know, such a huge such a huge subject can be covered, or 25 questions can come from that only. Right? So I don't know, you know, people talk about strike rate. I don't ever mention it personally. You must not have ever heard it from my mouth. The whole idea is that these are the most frequently asked topics. Read that topic, do questions from that topic, understand in a manner, because you will not get copy paste questions, you know, even repeat question. That is why, you know, a lot of they have been asking about RH negative. I am discussed 2 questions for RH negative with you people, right? But that doesn't mean that question aayega. I am assuming, right? So we've done all the clinical approaches so far. Right, so I will not give the word that I cannot give my word for that everything will come from LRR. No, okay, that sort of thing doesn't happen mostly. Right, so revision, yes, you can have your rapid revision. You can go back to your rapid revision videos, right? You quickly scrape through them, right? Or you just read your notes through the rapid revision, and then you can see the sort of questions that have been discussed. Okay, so what you can do is, so if you're going for rapid revision videos for your references, right, and you're simultaneously doing questions, right, so then LRR becomes supplementary in that. LRR becomes an opportunity for you. The whole idea about LRR and going live with it is so that we can take up your questions, you know, and take up your doubts. So that exercise is important. Now, okay. Your LRR is very similar to your lab 2 only. It is just that LRR is more condensed, it is more brief. So it is quite possible that you may have to go to your lab 2 notes. If you're seeing LRR as your only source, if that is what you're going to look at only, then please supplement it from elsewhere. You know, you'll have to supplement it with notes, you will have to supplement it with your questions, you know. So you will have to do that. All right. And PCOD का नाम चेंज हो गया, हाँ बस नाम ही चेंज हुआ है, that's all. Okay, PCOS is now going to be called PMOS, polycystic polyendocrine metabolic ovarian syndrome. It's just a change in name. The pathology is the same that you read. The diagnostic criteria are the same. See, the whole idea of changing the name was to create awareness. Okay, as gynae students or as gynecologists who are teaching these patients, as students who are preparing for this exam, you all know that it is all about other underlying insulin resistance, hyperinsulinemia. It's a metabolic derangement, not just the ovary issue, right? So it is about raising awareness and creating awareness that it's not just an ovarian problem. It's a whole of an endocrine and metabolic problem, right? Fine. So we'll end the session for today now. Chalo. Right? And I was telling you that I will बंद कर दिया क्या? Yeah. And I was telling you that I will be sharing the PDF. So there are the PDF for this session you can find. See, there's a Resolve Telegram group. The Resolve students must be aware of that, right? So you can get it there. I'll put it there. And the other thing I can do is that I can post it on my Telegram channel also. So you can search it by my name. You can on my Insta bio, you know, there is the link to the Telegram channel is there. So you can find me on Telegram also. Personally, you can find me on Telegram, and the Resolve group also is there. So I can post it there. I'll do it today. Okay, both places I will put it. All right, chalo then. Ending for now. All the best for your upcoming exam. I think now I'm going to see you next with your recall session, you know. So all the best. all the best. Keep reading, keep doing questions, right? If the whole idea is to now at this last moment, just let everything go from in front of your eyes, right? So wherever you have made your notes from, you have made it from Resolve, you have made it from other person, you have made it from the main video, whatever your condensed notes are, you go through that and you take the opportunity of these sessions for, appreciating how questions are solved, what sort of questions are asked, what are the questions, from which topics questions are being asked. Okay, but you stick to your material, don't add anything new. Okay, हम लोग घूम फिर के वही पढ़ाते हैं, whether it is LRR, whether it is a YouTube session, the topic remains the same. Okay, keep that in mind. Chalo, bye bye, take care now.